Hello, hello, hello. Good morning, all of you. Good morning. Am I visible to all? Am I audible to all? Is the audio video all clear? Yes. So I think I'm visible to all. Am I audible to all also? And all of you can hear me. All of you can see me. Okay. So welcome to the session. And yes, quickly all of you join in. We're starting in a minute. Yes. So everything good. I think welcome all of you to our session. Just a quick recap and a recap. I think is the audio video all clear, and I think whatever I'm writing also now, I'll be just be writing something. Yes. So can you see? Yes. Is it all okay? Yes. Yes. Okay. So, welcome all of you to our session. Just a quick recap and a recap. Previous week we have discussed majority of entire gynecology. Saturday we started with obstetrics and thumbs up if you recollect. We discussed very. Please go and see that video. Those who are not there live, trisomy 21, absolutely superb. Everything we've discussed. What are the confirmatory tests, screening test, double marker, triple marker, NT scan, sandal gap, everything I have shown you. Very important. Then the test for fetal well-being, NST, BPP, all that we discussed. And very important drugs, oxytocin, methergin, and how the action differs, oxytocin, methergin, and your various prostaglandins, based on which surely the question comes. And then we discussed about the USG in early pregnancy. So all this is very important topic. You definitely get questions on this, and those who haven't seen live can also go and see the recorded version also. And now and then we also discussed something very important about the HCG hormone, that how it is the earliest to detect pregnancy. Okay, so just a quick we begin our we begin this with a revision of 2 MCQ, so that I know all of you understood. And then what is the agenda for today? So today, starting part, something to do with the placenta, where you get 1 MCQ. Physiological changes during pregnancy, short topic, may or may not come, but we will teach you anyways. And then very important, active management third stage labor. Short MCQ is coming on this active management third stage labor, what it is, how it is, all that we'll discuss. And mechanism of normal labor also, questions are not coming, but I will teach you anyways the normal labor mechanism and what all. And then time permitting, I think yes, of course, because this will take around physiological changes and placenta around 1 hour. And this, so we will be starting with the very important topic of malpresentations, which is very important. You get MCQs on breech and brow and transverse and all that. Okay, so with this as the background, just very quickly, if I ask you, which of the following is the earliest to detect a pregnancy? It's a revision. We have transvaginal sonography, transabdominal sonography, urinary HCG, and serum HCG. Can anybody tell me earliest to detect a pregnancy. Pregnancy. Very good, all of you, superb. Okay, sir, the blood of the patient serum beta HCG will become positive even before missed periods. Yes, even before the patient misses the period, even before she misses her period, before missed periods, this will become positive. Then just after missing period, the urine test, and of course sonography is slightly later. But if I say to detect live pregnancy, earliest to detect live pregnancy, now what is our answer? Yes. No, but all no, I had sent two, Imad, I had sent two PPTs. One was in the morning, one was in the evening. So please say that all PPTs are sent. Yes. Okay. Yes. Transvaginal sonography, because when it is a live pregnancy, I have to see the baby heartbeat, which is called as fetal cardiac activity, which is earliest, because just remember that HCG cannot tell you live pregnant. HCG will just tell you pregnant positivity hai. Somewhere in the body there is pregnancy. Whether that pregnancy is inside the uterus, outside the uterus, everywhere there would be HCG positive. So that I need to confirm by doing only a ultrasonography. Now, two things, and again a very popular MCQ in a normal healthy. Why am I using the word healthy? You will come to know. In a normal healthy intrauterine pregnancy, what is the doubling time of beta HCG? What is the doubling time of beta HCG? Anybody? How much? What's the meaning of doubling time? Doubling in the blood. Anybody? Very good. 48 hours. Okay, please by heart this very famous MCQ. And what is the meaning of normal healthy intrauterine? I'll tell you. And because if it's not rising, what it is. Okay, so I'm telling you. Okay, now anybody, the HCG keeps on doubling. Okay, and can anybody tell me when does the HCG reach the maximum? In pregnancy, when does the HCG is maximum? Anybody? 7 weeks, 10 weeks, for 20 weeks, 30 weeks, 40 weeks. Okay, maximum HCG is when? During pregnancy. Anybody? 40 weeks? No. Okay, so 5 months, wrong. Okay, so remember students, very important one, thoda slightly more. Okay, maximum. Remember 2 ka figure. Whatever I told you about HCG is a trick clap if you feel happy. 2 figure. What 2 figure? Two components alpha beta, doubles every 2 days, 2 days or 48 hours, and maximum HCG seen at first double digit number or first 2 digit number. Which is the first 2 digit number? All of us know first 2 digit number is 10 weeks. So it is 9 to 10 weeks, basically 60 to 70 days of pregnancy, because 7 days make a week. 9 sevens are 63 days. 10 sevens are 70. Okay. So 60 to 70 days or 10 weeks is the maximum of HCG. Thereafter it plateau. Thereafter it drops. And then it will plateau. It will remain high throughout pregnancy. Okay. And now this is very important. Suppose today I deliver the patient. Okay. See, the HCG level goes up highest, then thoda sa drop down, then it will remain high throughout. So this maximum levels is at say 9 to 10 weeks. Then it keeps on dropping down. This slightly lower level is somewhere happens around 16, 18 weeks, and then throughout pregnancy, HCG is high. Okay, suppose say this is 28 weeks, 34 weeks, 40 weeks, like that. Okay, now suppose here for 38 weeks and 40 weeks. Now suppose here the delivery takes place. Okay, here the delivery takes place. What happens to HCG after delivery? It keeps on becoming less. Every day it will become dropping down. So it goes up in 1000, 50,000, 1 lakh तक जाता है. So 30,000, 20,000. How much time will it take to completely return back to normal after delivery? Suppose ये point पे delivery हो गया, I'm writing D. After delivery, when does the HCG return back to normal? मतलब not detected, because normally means it's not there. Okay, values less than 5 is considered normal. How much time it takes? 7 days, 14 days to. So again, remember Gancham slide. Okay, again 2 weeks. So clap if you feel happy. Sub 2 hai. It returns back to normal 2 weeks postpartum. Okay, postpartum 2 weeks it returns back to normal. Okay, so the answer is 2 weeks. Okay, after delivery it is going to take around 2 weeks time to return back to normal. That does not, so please understand, no point, we don't do the beta HCG levels or urine test post pregnancy, but just I'm telling you that if a lady has just delivered and tomorrow you collect her urine and then you do her urine test, that is still be, that urine test will be positive. That does not mean she is pregnant. Okay, so pregnancy test can also indicate a postpartum period, like, but it will keep on decreasing every day. So we don't check it. Just I'm telling you that after delivery, every day will become less, like 50,000, 30,000, 20,000, 10,000, like that. Come hote, it will take another 2 weeks and then become normal. Is this understood to all of you? Okay, so please keep in mind. Now, can anybody tell me, as I said, okay, in a healthy intrauterine pregnancy, we are keeping on telling you that the HCG is rising every 48 hours, it is doubling. Now, can anybody tell me, suppose HCG is not doubling, what does it indicate? Yes, sir, level was example 1000. And after 48 hours, what is normal? So 2000 is considered normal. Very good. But I do the level, it is 1000, and after 48 hours, it is only 1200 or 1300. What do I have to think in mind? Very good, all of you. Okay, sir, in ectopic pregnancy, it will increase, but it will not double, and that is a clue. And that is why in ectopic, when there's a confusion, we always repeat 2 levels. One level is not important. We have to wait for 48 hours and then repeat and see for the jump. If the 1000 is becoming 2000, very good. If 1000 is becoming only 1200, 300, that is ectopic pregnancy. And other thing is also, if it's a failed pregnancy, suppose the pregnancy is not healthy, so ectopic is one of it. And other thing is, let's suppose it's a failed pregnancy, like missed abortion, we'll discuss all that. Okay, or patient is just about to abort, or the pregnancy is not going to grow, then also we can get such a minimal rise only. Or sometimes even if the bleeding starts, it can even get a drop. Okay, if a patient has bleeding episodes and 1000 becomes 800, that means the level is declining. Okay, so decreasing level is also not good. Decreasing level tells me that now the pregnancy is going to abort. Patient will abort. What are the different types of abortion? All that we are going to discuss in this tomorrow, day after tomorrow lecture. Okay, missed abortion, threatened, all that I'll explain to you. Don't worry. Okay, so just remember that HCG doubles. If it doubles, excellent. If it does not double, then I have to think of ectopic pregnancy. That's why we keep on saying that in a normal, healthy pregnancy, and it's an intrauterine pregnancy, it doubling time is every 2 days or 48 hours. Is this understood to all of you? So this covers our last week topic of HCG, which was remaining. Now moving on to the placenta and its variation. One question comes, but before that, what is the main blood supply of the pelvis? Now all of you please pay attention. This is actually a anatomy MCQ. Even if you don't remember this whole table, I am okay. That the main blood supply is internal iliac artery. It has got anterior division, posterior division. एंटीरियर डिवीजन से आता है यूट्राइन वेसल्स, वजाइकल, ऑब्ट्यूरेटर, पुडेंडल, रेक्टल, वजाइनल. And posterior, remember SIL, superior gluteal, iliolumbar, lateral sacral. SIL, superior gluteal, iliolumbar, lateral sacral. Even if you don't remember this whole table, I am okay. just all of you remember that the uterine artery, it is compulsory for me to remember that uterine artery arises from the anterior division of internal iliac. Can anybody tell me why is it important to know this? Which topic we will discuss tomorrow, it is important to know that yes, uterine artery is a branch of internal iliac, but the anterior division of internal iliac and not the posterior division. Anybody? Very good. Ghanshyam LSD. How in PPH management? Anybody? How in PPH management? Yes, there's heavy bleeding. So what you do? So yes. So first we will ligate the uterine vessel. We'll ligate the uterine vessel, and still if the bleeding is not coming under control, we will ligate the internal iliac artery, but the anterior division, not the posterior division. So therefore remember tomorrow when I teach you PPH, and in that when we discuss about ligation. Now please understand, ligation is just a temporary method. The whole uterus will not undergo necrosis. There will be collateral vessels. But when you undergo ligation, which division we have to ligate? First you ligate the uterine artery. Okay. And after uterine artery ligation, if still the bleeding is not coming under control, then you ligate the anterior division of internal iliac. Okay, anterior division of internal iliac artery. Okay, anterior division of iliac artery has to be ligated. So just keep this in mind. All these points will be repeated tomorrow morning. Don't worry, but keep in mind that uterine artery is a branch of anterior division of internal iliac. Okay. Okay, is it clear to all of you? Yes. Now please keep in mind. Now, moving ahead. Now, placenta, few points, variations also we will teach you. The anybody, what is the weight of the normal placenta? Very big. These were MCQs asked many. Now these questions don't come. 2010, 11, 12 ऐसा question आया. Weight of normal placenta. Okay, 200 grams, 700 grams, 500 grams, 1 kilo. Yes. So weight of the normal placenta roughly around 500 grams. And can anybody tell me now ratio of baby weight to placental weight? Ratio of baby birth weight to placental weight. चार ऑप्शन देंगे आपको. 4:1, 6:1, 1:4, 1:4. A, B, C, D. All of you please participate. I want all of you to answer right, wrong. Yeah, and as usual, all of you are aware, but those who are new, we are not using the chat box in the lecture series, on the Class Plus app. We are using the Telegram channel, okay? Because I'm not able to see both simultaneously, the chat box and this, okay? So I will request all of you to please answer only on the Telegram group. If anybody is not the member of the group, then kindly please join the group, okay? We have got 155 students, I think. Yes, very good. So please pay attention that never is it possible. ये उल्टा नहीं याद रखना है. 6:1 is the answer. How you get it also I will tell you. But if we interchange the MCQ. If the question asked is ratio of the placental weight to baby weight, now what is the answer? Placental weight to baby weight पूछा, then 1:6 is the answer. So this looks very simple. It's your mathematics. It looks very stupid. कह रहे सर ये क्या सिखा रहे हैं? But these students have made a mistake in the heat of the examination. So remember, dear students, that roughly when 3 kilo is the baby, that means 3000 grams, then 500 grams is the placenta. So when you divide, you get it 6:1. So 6 part is of the baby and 1 belongs to the placenta. So the ratio, if they ask you the first thing this, then you ask this. Baby weight पहले पूछा है, then put the baby का 6. Placental weight second hai, then put placenta. Okay, is this understood to all of you? Okay, and the placenta has got two components, the maternal and the fetal. Decidua. What is decidua? The part of the uterus. The part of the uterus which contributes to placenta is called as decidua. Decidua basalis. Very famous is the mother's part. And chorionic villi. All the chorionic villi is the baby ka part. Okay. So chorionic villi is considered the fetal component and maternal component is deciduo basalis. Questions are not coming on this, so you don't have to weight of the normal placenta 500 gram, diameter 15 to 20 centimeter. Yes, correct. So that is what this question has come. I told you what contributes to placenta, deciduo basalis. Yes. Okay, baki all this is not important, but yes, anything can come. There's mug up. There's no explanation in this. And this is what I told you: ratio of baby weight, birth weight of the baby. Okay, so baby birth weight to the placental weight 6:1. Okay, 6:2. And a term 4/5 of the placenta is of fetal origin. Okay. Okay. Now, anybody, which condition, these are again very, very simple but basic MCQs. Which condition do we get a bigger placenta? जो placenta होता है उससे बड़ा. What placenta is there? उससे बड़ा. Like big placenta. 3 conditions. Anybody, at least you should tell me 3 conditions that the placenta is big. Very good. Twins, common sense. Say twins, 2 babies. Placenta will be bigger. Diabetes, macrosomy. Okay, I come back to this in a minute. Okay, these are 2 MCQs. I'll explain to you in a minute. Yes. So big placenta, I will get in twins, diabetes, big baby, hydrops fetalis. What is hydrops? I discussed in the last lecture. And syphilis, second line. Okay, and syphilis also because of inflammation and edema, the placenta is going to be small. So all these topics we're going to cover in the next 3 days time. Don't worry. Okay, and small placenta, postdatism. What it is, I'll discuss Thursday. IUGR, last lecture, placental infarcts. Again, placenta is going to be small. Okay, so all these conditions is your this hydrops fetalis will just explain to you in detail. Don't worry whether this placenta is edematous. It's fluid collection, water everywhere. Okay, so these are all basic MCQs which last हाँ बेटा एवरीथिंग शॉर्ट वीडियो नहीं बेटा पूरा एक्सप्लेन करेंगे. ओके, शॉर्ट वीडियो एक्सप्लेन क्यों बेटा, पूरा डिटेल में 30 minutes वीडियो, नॉट शॉर्ट वीडियो. ओके, सो placentomegaly is seen in. Okay, so hydrops fetalis. Okay, so please understand. Okay, so these are the questions which were coming many years back, like simple one liners. Big placenta seen in all except, small placenta seen in all except. Okay, now 2 things, again no explanation, only mug up. 2 one-liner MCQ. Okay, uteroplacental circulation, that means first the connection between the uterus and the placenta. Okay, yeah, correct. So that, yeah, okay, so uteroplacental circulation, yeah, you can see, go and see all that YouTube shorts. They are very interesting, but when you listen to the lecture, everything will be covered anyways. Okay, 9 to 10 days after fertilization is established when and fetoplacental, matlab the baby and the placenta circulation established 21 days post fertilization. We can simplicity remember 10 and 20. 10 और उसका डबल 20 याद रखने के लिए. So first obviously the connection between uterus and the placenta is formed, and then fetus and the placenta circulation established around 20 days post fertilization. Everything is after fertilization. Okay, in this remember this. Okay, now can anybody tell me what is, and with pictures and diagram, now important because now all these questions have come. Okay, what is the meaning of succensurate lobe of the placenta? Succensurate lobe, what is the meaning? Anybody? Succensurate lobe means what? Okay, yes. So succensurate lobe means sir, there is a one big placenta or a normal placenta and a small accessory lobe which is present at the periphery. Okay, small accessory lobe present at the periphery, and both of these are connected by vessels. Now, anybody, what is the complication which can happen with this? What complication can happen with this? Very good. Okay, sir, the main lobe will get delivered and the small lobe can get retained inside, giving rise to atonic PPH. Okay, so basically tomorrow when I teach you PPH, beta Asherman nahi hoga PPH. Tomorrow when I teach you PPH, this one etiology ready from your side, sir, retained lobe of the placenta. Is it clear to all of you? Retained lobe of the placenta. Can you rest to no, primary bhi hota hai beta second. Okay, so retained lobe of the placenta. Is it clear to all of you? Picture I'm showing you in a minute. Now one more very important complication. Please understand this. On the second last day, I will teach you in detail. All of you pay attention. Very important topic where please pay attention. Normally, all of you know that the placenta is up and the baby is down. That all of you know. Iska ulta is what? Okay, sir, where the placenta is down and the baby is this and placenta is in front. What is this called as, anybody? This topic is called as placenta previa. The whole placenta is in front of the presenting part. This is called as placenta previa. This is called as placenta previa. Okay. Now, this I will discuss for 1 hour on the second last day. Okay, so ये पूरा separate lecture है. Why am I telling you? Because the words previa is similar, but students get confused. Now with this, so placenta previa is a separate topic. Okay, is a separate topic. Now with this kind of arrangement, succensurate lobe, with this kind of arrangement, the succensurate lobe, okay, with this kind of arrangement, the succensurate lobe, what can happen is that the baby could be over here. The baby could be over here and the fetal vessels are in front of the presenting part. Okay, matlab one of the placenta could be here, then there are the crossing of the fetal vessels and then another lobe over here. Okay, and this is the cervix and the baby could be over here. So this condition, very good, this condition is called as vasa previa. Now what is the importance of vasa previa? All that I'm going to discuss because it's a very important MCQ. Dhyan se sunenge. Okay, please pay attention. But before that, all of you pay attention. This I'm coming to it in a minute. Succensurate lobe, presence of one or more accessory lobe that develops at a distance from the main placenta. Okay, that develops at a distance of main placenta. The accessory lobe is retained, giving rise to PPH and also associated with vasa previa. Okay, is it clear to all of you? So now picture abhi baki hai. Yeah, that's okay. Very good. You have posted it. But now all of you can see this also. So can you see clearly? All of you clap if you feel happy. This was the actual image. This was image 2 years back in the exam. Okay, so this is the main placenta. This is the succensurate lobe of the placenta. Both pictures are showing the same. Both pictures are showing the same. And this also is showing you the same. This is the main placenta. This is the succensurate lobe, and they are connected by vessels. They are connected by vessels, which is important. So both these are images of succensurate lobe. Again, one more image just for this. Yes, the same picture is there. Okay, so if you can see, others I'm explaining you in a minute. Okay, so if you see over here, this is also the same thing. This is the main placenta, accessory lobe, and connected by vessel, the succensurate lobe of the placenta. Now, can anybody tell me? Can anybody tell me? Can anybody tell me? So, yes, succensurate lobe. Now, can anybody tell me that? Yeah, we are explaining. Okay. Now, this vasa previa, what I told you, very, very important. This vasa previa is a vasa previa is a vasa previa is a very, very dangerous condition for whom? Okay, vasa previa is a very, very dangerous condition for mother, baby, or both mother and baby. If I tell you that vasa previa is a very, very dangerous condition, only the mother, only the baby, both mother and baby. And why? So vasa previa is very, very dangerous for the baby only. Remember this. Why? Because in placenta previa and abruption, the baby can have a problem, but it's a mixed maternal and fetal blood loss. Mixed. But in vasa previa, remember when the vasa previa ruptures, please all of you will write down exclusively fetal blood loss. So what will happen also, it is very, very important to know, and how will the patient present also, I will tell you. So it's a very difficult MCQ. Never asked till now. The vasa previa clinical case never asked till now will come in the future for sure. Okay, I repeat, vasa previa is exclusively fetal blood loss. पहले इतना याद रखना है. So what will happen? What will happen? Anybody? So there is fresh bleeding. There is fresh bleeding, thoda sa bleeding, followed by acute severe fetal distress. Anybody? What is the meaning of acute severe fetal distress? Okay, acute matlab rapid, severe matlab severe, and fetal distress matlab the baby heart rate dropping down. So example, agar suppose baby heart rate everything is fine, baby heart rate is 140 per minute, I told you, and there is a bout that vasa previa rupture, bleeding, slightly fresh bleeding, immediately heart rate drops down to 70. So ekdam severe. Yes, severe and acute. Acute means very quickly. And then what happens? Cut, 70, 60, 40, 20, 30, 0, baby dead. There is rapid FIUFD, intrauterine fetal death. Okay, rapid intrauterine fetal death. Okay, so this is we are discussing everything. Okay. Meta management, not only if about 32 weeks also we'll discuss. And if at 36 also we'll discuss. And okay. So first understand कि इतना quickly You will say, oh my God, there is fetal distress. What do you do normally in fetal distress? You shift the patient to operation theater and go for LSCS. Remember, any fetal distress we are supposed to deliver very quickly. Most of the time we have to do LSCS. Okay, so in any fetal distress we have to do very quickly LSCS, and we have to save the baby. But here, even before you do the LSCS, very rapidly the baby dies. Okay, there's rapid intrauterine fetal death. Okay, there's very rapid intrauterine fetal death. So this is the meaning of your this that whenever there is a ruptured vasa previa, there is going to be fresh bleeding. There is fresh bleeding, which is followed by fresh bleeding, which is followed by acute severe fetal distress, and even before you get a time to do LSCS, there is rapidly IUFD, the baby dies. Is this understood to all of you? And ye sub mein the important part is mother stable. They will give you mother is stable. So suppose this MCQ comes, okay, virgin MCQ, okay, there is fetal bleeding followed by there is fresh bleeding, followed by acute severe fetal distress, followed by rapid fetal death, and the beta no painless painful bleeding. Beta don't get confused, Sanjay. That is with abruption and placenta pre. Uska abhi confusion mत करो, but painless bleeding. Okay, and painful bleeding, abruption, all that is in the last class. Okay, don't bother right now. Okay, so the fresh bleeding, because it's a very small bleeding, followed by acute severe fetal distress, rapid fetal death, and surprisingly, they will tell you mother is absolutely stable. Okay, sir, such a big complication happened that baby died, but still mother is stable. Mother stable matlab pulse 70, BP 120, 80, hemoglobin 11. If this is the clinical case given to you, what is your answer, all of you? What is your answer? Ruptured vasa previa. Rupture vasa previa. Is this understood to all of you? Why I am discussing vasa previa over here? Because there are two conditions which I will tell you which are associated with vasa previa. One I already told you, succinturate loop. Okay, so fresh bleeding is followed by acute severe fetal distress, followed by rapid fetal death. Now, management coming in a minute. Can anybody tell me? What is the investigation of choice for vasa previa? Investigation of choice for vasa previa. KB test. KP test, app test. हाँ बेटा मोनाली what repeat one? हाँ I'm repeating everything बेटा. Okay, yes. Investigation of choice for vasa previa. Very good. Excellent, excellent, all of you. I am so happy that you all have selected color Doppler as the answer and not this stupid app test. What is the app test? I will tell you in a minute. But please write down, underline boldly, because certain books written by non-gynecs are giving this is the answer. Please remember this, that the investigation of choice for vasa previa is what? Is not app test. Okay, app test is stupid kachra dustbin. Why it is stupid kachra dustbin also you will come to know in a minute. And but when is the app test the answer to the MCQ? Everything I'm explaining you in 5 minutes. Please pay careful attention. Okay, when I say what is the investigation of choice, please understand this. We would like to do the diagnosis and save the baby. So color Doppler, whenever I want to see anything to do with the blood vessel, जब भी blood supply का कुछ देखना है, remember it is color Doppler. Example, in surgery, lower limb DVT, color Doppler. Next class, next lecture, IUGR, blood supply to baby, color Doppler. So wherever I want to see blood vessel flow or blood supply, it has to be color Doppler. Okay, color Doppler. So color Doppler is the best investigation or investigation of choice. Why? Because we can make the diagnosis And common sense, can you please tell me, if the diagnosis of vasa previa is made, I have made the diagnosis of vasa previa, how will I deliver the patient? Obviously, sir, elective LSCS to be done. Don't even, that's your answer. Okay, somebody asks, what's the management? Don't even allow labor to start. Moment you reach 37 weeks, because after 37 weeks, anytime the labor will start, and you can imagine, okay, once the labor will start, if these vessels will rupture, okay, if the vessels will rupture, then there is so if the vessels, basically fetal vessels, are crossing the cervical opening, fetal vessels are in front of the presenting part. Okay, so when the uterine contraction will start, the cervix will open up, these vessels will have a bleeding, and the baby will very rapidly die. So even before the labor starts, elective LSCS to be done. Is this understood to all of you? Vasa previa was a complete MCQ 3-4 years back in the NEET PG. I repeat, those who wanted to repeat also, Monali, now please pay attention. Okay, please pay attention. I repeat, these are the 5 points to be kept in mind. Point number 1, it is associated with succinturate lobe. Point number 2, it is exclusively fetal blood loss. Point number 3, there is fresh bleeding followed by very rapidly the baby dies, that is rapid IUFD, and the mother is stable. All this is again because it's a exclusively fetal blood loss. So the baby will have a problem, mother will not have a problem so much. And the important point to be kept in mind is color Doppler is the investigation of choice. Color Doppler is the investigation of choice. Very, very important MCQ. And if I make the diagnosis, how do I deliver the patient? Sir, elective LSCS to be done, because that is why it's called the investigation of choice, and elective LSCS to be done to save the baby. So when the bleeding starts and you do LSA, that's called emergency LSAs. But here, even before the emergency situation happens, elective LSAs. Elective means everything is fine, planned cesarean section. Okay, elective LSAs to be done. Now, can anybody tell me what is it clear, Monali? You understood? Okay, now can anybody tell me what is this app test? Why am I calling it stupid kachara dustbin? And still, when will app test be the answer to the MCQ? Okay, so please pay attention. App test, first of all, remember, is not the investigation of choice for vasa previa. Now, app test kya hai? Only for time pass. Only for time pass and CID investigation. Okay, दया कुछ तो CID. Okay, ACB प्रद्युमन कुछ तो गड़बड़ है दया. Okay, ACB. Okay, तो क्या है वो कि if I give you a blood, if I give you a bottle of blood or a small ampule of blood or a vial of blood, and if I tell you, okay, please find out whether this blood belongs to the mother or the baby. ये खून किस दया, ये खून किसका है, माँ का है कि बच्चे का है. Okay, so what you do is that you take this blood. Okay, you take this blood, and to that you will add 10% sodium hydroxide, and then you will put under the microscope, and you will see whether it denaturates or not. Okay, you will remember the dictum that fetal hemoglobin is resistant to alkaline denaturation. Fetal hemoglobin is resistant to alkaline denaturation. Okay, fetal hemoglobin is resistant to alkaline denaturation. This is called as app test or Singer's test. I repeat, the fetal hemoglobin is resistant to alkaline. That means if the blood get denaturates, it is of the mother. and it does not get denatured, then it is of the baby. This is called as app test or Singer's test. So this is called app test or Singer's test. So when is this the answer? If the MCQ is how to differentiate between mother and fetal blood. Suppose you get an MCQ, how to differentiate between mother blood and fetal blood, and the option are A test, B test, C test, D test, then you mark app test as the answer. Okay. I repeat that whatever blood is there, to that we will add sodium hydroxide, 10% sodium hydroxide, NaOH, and then we will write fetal hemoglobin is resistant to alkaline denaturation. This is the app test or the Singer's test. Okay, is it clear to all of you? App test or the Singer's test, and this is because fetal hemoglobin is resistant. Now, common sense, all of you tell me. Common sense, all of you tell me. Okay, when the bleeding happens, when this bleeding is happening, when this bleeding is happening, will, because ये alkali अपना लेबर वार्ड में नहीं होता है, माइक्रोस्कोप लेबर वार्ड में नहीं होता है. So when the bleeding happens, you will not tell your junior, jaldi bhago, go to microbiology department, get me the alkali, और go to biochemistry department, get me alkali, फिर उधर से भागते भागते go to the pathology department or micro, get me the microscope, I will mix everything, I will put in a microscope and I will check and do. No, we are going to shift the patient for operation date. Okay, and do LSC. So when I say investigation of choice, please understand this, that I want to save the baby. Only way I can save the baby is by doing elective LSCS, and color doctor will tell me, hey, yes doctor, now please you do LSCS, because it is vasa previa. Is this understood? Can I get 10 thumbs up? And please understand, app test I'm already doing when the baby is already dead, isn't it? It's only for time pass. This blood is there, baby now already dead. अभी खाली investigation ACP time pass कि ये sir this blood is mother or baby. Is it clear? So practically, that's why I tell this कि app test is outdated, stupid, kachra dustbin. Only for MCQ we do this study. Otherwise, practically in my whole life, I have never done this app test. In my whole life, I have never done the app test. Neither my senior nor my junior, nobody has done this test. Okay, that the app test is that the blood which you take, and if it is fetal hemoglobin is resistant, and mother's hemoglobin will get denatured. Okay, so that is this. But this they can ask you that what is the alkali used? Sodium hydroxide. Okay, is it clear to all of you? So this is not routinely done. This is hardly ever done. This is only for this, and the investigation is vasa previa. Okay, so I repeat, vasa previa is associated with succinturate lobe, exclusively fetal blood loss, and do color Doppler before it ruptures and do LSCS to save the baby. Otherwise, the baby will die because it's going to be acute severe fetal distress and rapid fetal death. Okay, mother will be stable. Next, anybody, what is the meaning of Battledore placenta? So Battledore placenta means that there the placenta is like this, and placenta is like this, and the umbilical cord will come and attach to the margin or the periphery of the placenta. Okay, umbilical cord will come and get attached to the margin or the periphery of the placenta. All of us know normally umbilical cord has to come right to the center. Umbilical cord is attached in the center. Okay, but if the cord gets stopped over here and from here the vessels will pass like this, this is the Battledore placenta. Okay, so battles happen at the margin or periphery or whatever. Okay, so Battledore placenta. Okay, is it clear to all of you? So when the umbilical cord is instead of the placental margin or the periphery, that is the Battledore placenta. Okay, so you can again see this. So all the pictures, also everything I'm showing you. Okay, so this is your Okay, so this is the battle. You can clearly see this is the placenta, and the umbilical cord is stopping at the margin or the periphery. That is the battledore placenta. Okay. Okay. Yes. And again, clap if you feel happy. Clap if you feel happy. This is my actual picture. Nobody will show this actual picture. All of you must have seen only the picture in the diagram form. This is one of my patient. I also saw it for the first time. Okay, so very happy that some many few years ago we delivered a patient, and I immediately clicked the photo for the students' benefit. Okay, so here you can clearly see that the umbilical cord is stopping right over here. Okay, umbilical cord is stopping right over here, and the vessels, otherwise umbilical cord would have gone till the center over here. Okay, so definitely this is some variation, and this is the battledore placenta. This is the battledore placenta. Umbilical cord inserted onto the placental margin or periphery. Clearly the cord is stopping over here only. Okay. Okay, next, anybody, so ये सब सारे questions आ सकते हैं. And anybody, last is, what is velamentous insertion of the umbilical cord? So in velamentous insertion is कि umbilical cord will not only go to the does not reach to the center, it does not even reach to the periphery. What will happen, anybody? In velamentous insertion, the umbilical cord will be attached onto the fetal membranes only, far away from the placenta. Far away, मतलब गाड़ी बहुत पहले अटक गया. Okay, so the umbilical cord is inserted onto the placent in the fetal membranes, and from here the vessels have to run towards the center. So even this part, okay, so this is velamentous insertion. Even this part is associated with vasa previa. Okay, so can you tell me two conditions associated with vasa previa? All of you look on the board. These are the two conditions. You can see the velamentous insertion, the umbilical cord is inserted onto the fetal membranes, and that is vasa, associated with vasa previa. And succinturate lobe is also associated with vasa previa. Okay. Okay, so all these are the important MCQs which could be asked to you. Is it clear to all of you? So succinturate lobe, battered placenta, velamentous insertion, and this is very important. Okay, so succinturate lobe picture done. All of you, yes, all thumbs up. Then investigation of choice for vasa previa, color Doppler, and this is yes. The last part. Can all of you clearly see over here the Can you see this clearly? The velamentous insertion of the umbilical cord. Okay, velamentous insertion of the umbilical cord, where the umbilical cord is stopped over here, and there is the placenta over here, and the vessels are running towards the this. Okay, is this understood to all of you? Is understood to all of you? Yes. Okay, so these are very important MCQ. Okay, so the last part, the circumvallate placenta, again never, I'll just explain to you also. So first of all, vasa previa investigation of choice color Doppler and not the app test or the singles test. Is this understood to all of you? And Vasa Privya, we have to go and do elective LSCS. Okay, elective LSCS. The last thing is the circumvallate placenta. It's a double fold. It's a double fold of the chorion and amnion on itself. So basically there's a central depression surrounded by a thick white grayish ring. Okay, so this is a circumvallate placenta, and ring is, as I told, double fold of amnion and chorion. Basically nothing much about it. It is associated with IUGR, can have IUGR. Okay. Okay, so this is a circle. Basically क्या होता है, as you can see, then there is a double fold of chorion and amnion. So this what all of you were telling me, like this pani puri type. Okay, so this is what it is. Okay. Okay, so this is what it is, that circumvallate placenta, this thick white peripheral ring what you see. So the placenta is actually only this much part, and this much part becomes actually useless because this much part will not give any nutrition to the baby. Okay, so basically this is called as the circumvallate placenta, double fold of chorion and amnion, a double fold of chorion and amnion which is there, and therefore this part becomes useless, and there is not much benefit to the baby of this all peripheral part, the center part of the placenta which is actually functioning. Okay, now very uh, rarely asked topic, but a question can come on this, and various physiological changes which take place during. So all these are important. Yeah, the last part, anybody, umbilical cord. What is the length of the umbilical cord? Umbilical cord, what is the length? Okay, so 50 centimeter is what you can remember. Anybody, how many arteries, how many veins? It is called as triple vessel cord. Triple vessel cord. So yeah, 45 to 50 centimeter, very good. 45 also, if you remember, that's fine. 45. Okay, triple vessel cord, triple vessel cord. It is, yes. Okay, so two arteries, one vein. Two arteries, one vein. And what is that vein? Which is this vein? Left is left in the body. Okay, left is left. Okay, the right vein disappears. The right vein disappears. Okay, so this is the left vein, two artery, one vein, not veins. Okay, two artery, one vein, and that is the left vein. Left is left in the body. Okay, right vein, right will disappear. Okay, now can anybody tell me again? Okay, can anybody tell me? Can anybody tell me what is? Okay, yeah, what is the problem? There's excessively long cord. Okay, yes, right vein gets obliterated, or right vein disappears, left is left in the body. Very good. Okay, can anybody tell me if the cord is very long, there's no criteria, but 100 centimeter, 200 centimeter, तो क्या हो सकता है? Excessively long cord. Yes. Okay. So cord can get entangled, cord knotting of the cord prolapse. Okay. Cord can come out, and cord around the neck. Now, cord around the neck is the right word, but it is like normally you say strangulation. Yes, very well, but cord around the neck. So stylish way you want to say, you say nuchal cord. Okay. So cord around the neck is fine. But nuchal cord, when you say, it gives you more. Nuchal cord. Okay. Nuchal cord. It's like a style. Nuchal cord. It looks very stylish. Okay. Yes. So this. And short cord. If the cord is very short. then the baby will not suspend properly. So malpresentations, okay, malpresentation like breech transfers. And if the contraction is strong, the baby will come down. It can pull the placenta with it. Okay, so these are again very very rarely asked question. Right vein disappears, left is left, one vein, two arteries. Okay, so excessively long cord associated with cord prolapse, cord entanglement and knotting, and cord around the neck or the nuchal cord. Short cord, very short cord, 5 centimeter, 10 centimeter, can cause abnormal malpresentation or lie and premature separation of the placenta. Okay, so all this may be asked to you in the exam or may not be asked to you. Okay, now anybody very very as I said so this one question from whatever we discussed in the first 1 hour, one question may come. Okay, now please pay attention. The various physiological changes which take place during pregnancy, slightly a boring topic because there are 3-4 values. Luckily itna sara question kuch aata nahi hai, but may come. Okay, so cardiac output rises during pregnancy. Cardiac output increases during pregnancy. Cardiac output rises by 40% during pregnancy, 50% during labor, and immediately in the postpartum period there is a 80% increase in the cardiac output. Okay, I repeat, cardiac output rises by 40% during pregnancy. When, how, I will tell you in 5 minutes. 50% during labor, when the labor is there. So I'm writing intrapartum. And immediately in the postpartum period, immediate postpartum. There is a 80% increase in the cardiac output. Why this happens is, anybody, why this happens? Why this happens is that because after baby delivery, okay, after the baby delivery, the uterus will strongly contract. So whatever blood is in the uterine system enters back into the mother. So that is called as autotransfusion. I repeat, what is autotransfusion? What is autotransfusion? The mother's own blood will come back to the mother. खुद का, आपका खुद का ब्लड ही आपको वापस आ रहा है. ओके, सो वर्जिन एमसीक्यू. ट्रू नॉट इज अ लॉन्ग कॉर्ड ना, लॉन्ग कॉर्ड होगा तो नॉट होगा. ट्रू नॉट इज फॉर द लॉन्ग कॉर्ड. लॉन्ग कॉर्ड में नॉट्स. ओके कि नहीं? शॉर्ट कॉर्ड में देयर इज नो चांस ऑफ गेटिंग नॉटेड. Yes. Anybody, what is the meaning of autotransfusion? Virgin MCQ. If I tell you autotransfusion is seen when? Is seen at 20 weeks, 40 weeks, intrapartum, immediate postpartum. What is the answer? बेटा you tell me, auto transfusion of what? Transfusion किसका होता है बेटा? Okay, so this was the question. Now I'll explain to you in a minute. Yes. Okay, but a transfusion of what? What is auto transfusion? Okay, so of course virgin MCQ and many students clean blood. Okay, so auto transfusion means the mother's own blood. Okay, beta blood का बात हो रहा है. Okay, medical. Okay, so the mother's own blood is coming back to the mother. This is called as auto transfusion, and this is immediate postpartum. Okay. Immediate postpartum. Okay. So now please pay attention. Please pay attention. Yeah, yeah. Okay. So no problem. So I'm explaining to you. Ha. Please pay attention. Why this happened, beta? You tell me, beta. You tell me why this happened. Okay. So please pay attention. Point number one: cardiac output rises by 40% during pregnancy, 50% during labor, and immediately in the postpartum period, there is a 80% increase in the cardiac output. Why this happens? Because after delivery, the gravid uterus compression gone. Okay, so IVC return, because otherwise during pregnancy the uterus presses the IVC. So IVC compression gone. So venous return better, and the uterus will strongly squeeze. Yes or no? After delivery, uterus has to squeeze very softly, very strongly. So whatever blood is in the uterine system enters back into the mother. This is called as auto transfusion. That's why it is called auto transfusion. मतलब mother's own blood. जो blood uterus में था वो mother का ही है. So mother's own blood comes back to the mother. Is this understood to all of you? Yes, RR and Medico understood. Okay. Okay, the mother's own blood comes back to the mother. This is called as auto transfusion. Can I get 5 thumbs up? And that is, this is not important. ये छोड़ दो. ये सब याद नहीं भी रखा तो ठीक है. Can anybody tell me? Can anybody tell me that is why a normal patient, a normal patient will easily tolerate this 80% increase in the cardiac output. Okay. What one drug, what one drug I will give to heart disease patient? What one drug I will give to heart disease patient immediately after delivery? What one drug we give to heart disease patient immediately after delivery of the placenta, which will be repeated on next upcoming lectures also. Yes, IV diuretics, very important MCQ. That's a normal patient. Everybody will have this 80% increase in the cardiac output. So maximum cardiac output seen when after delivery 80%. Okay, 80% above the pre-pregnant level. So here everybody can tolerate this 80% increase in the cardiac output. Okay, everybody can, everybody can everybody will have this 80% increase in the cardiac output, but the heart disease patient will have a problem, and therefore in heart disease patient immediately after delivery we are supposed to give IV diuretics or IV furosemide. Don't worry, all these points I will repeat in my heart disease lecture also. अभी के लिए खाली याद रखो कि cardiac output rise by 40% during pregnancy, 50% during labor, and immediately in the postpartum period 80% increase. And if you get this MCQ, auto transfusion is seen when? Auto transfusion is seen when? What is the answer? Auto transfusion is seen when? Immediate postpartum. Okay, immediate postpartum. Okay. Okay. Auto transfusion is seen when? Immediate postpartum. Okay, is it clear to all of you? Now, this cardiac output, what I told you, this cardiac output, what I told you, begins to rise from the first trimester itself. This cardiac output begins to rise from the first trimester itself. And can anybody tell me this maximum, जो 40% लिखा है, maximum cardiac output is when? This maximum cardiac output is when in pregnancy. Anybody? 10 weeks, 20 weeks, 30 weeks, 40 weeks. 10, 20, 30, 40 चार ऑप्शन दिया. When is cardiac output maximum during pregnancy? I'm talking. उसके बाद और भी है, you know. After pregnancy, it will be more during labor, and still more maximum is when after delivery. But during pregnancy, when is it maximum? 8 weeks, 50% is after. Yes, no, but when? I'm asking 8 weeks. No, no. Okay, so remember students, 10 weeks. No. Okay, this cardiac output is maximum. Okay, this cardiac output begins to rise. Yes, very good. The cardiac output begins to rise from the first trimester and is maximum at around 28 to 30 weeks. Some books mention 28, some mention 30. So very good. This always they'll give you in the exam a range, and 28 to 30 weeks or 28 to 32. Okay, that is the time when the cardiac output is maximum, and that is the danger period for heart disease. If the question is that when, you see, all this is problem with not normal patient, heart disease patient. When MCQ, very famous MCQ, when heart disease patient likely to develop, likely to have, or maximum risk, when is the maximum risk? Okay, if the question is that when heart disease patient maximum risk of cardiac failure, very good, all of you, very good, all of you. And if your options are 10 weeks, 20 weeks, 26 weeks, 32 weeks, then please all of you mark 32 weeks as the answer. Because sir, when at around 30, yes, third trimester, when at around 30 weeks the cardiac output is maximum, so immediately after that 32 weeks is the danger period. 32 weeks is the danger period for heart disease during pregnancy. But if the option change, answer change. Okay, if any weeks are given, then mark 32. Okay, 16, 18, 20, 32. But if intrapartum is in the option, then that is also more risk, and immediate postpartum is the maximum risk because it's 80. So it's like similar 40, 50, 80. Okay, so now all of you tell me the answer. Suppose the question is this: when is the heart disease patient maximum chance of failure? A, B, C, D. All of you know this. Okay, when the heart disease patient maximum chance of failure, 32 weeks. Okay, but the problem with student is they are mugged up 32 and they literally cannot see beyond 32. Now suppose if the question is same question, okay, when heart disease patient maximum chance of failure, and suppose options are 24 weeks, 32 weeks, intrapartum. Now what is the answer? Anybody? 20 weeks, 24 weeks, 32 weeks, intrapartum. हाँ मतलब सॉरी, now mark, okay, A, B, C, D. Now what is the answer? Yeah, I added A before here, so that, yeah. So then very good. Intrapartum D is the answer. Clap if you feel happy. So this is how see question change, answer change. Okay, when sir only weeks are asked, anything to do with the weeks, we'll mark 32 weeks. But here 32 weeks pe what is the cardiac output? Sir cardiac output is 40%. And intrapartum में कितना है? 50%. Okay, 50% the cardiac output is rising, 50%. Okay, and now suppose if the options are 24 weeks, 32 weeks, intrapartum, and immediate postpartum. Now what is the answer? सुपर, समझ में आ गया आपको? सो प्लीज रिमेंबर कि इट इज सिंपल 40-50-80 बिकॉज जितना कार्डियक आउटपुट बढ़ता है उतना रिस्क इज मोर. सो आई रिपीट, मैक्सिमम चांस ऑफ हार्ट डिजीज फेलियर गोइंग इन कार्डियक फेलियर is immediate postpartum period followed by intrapartum period followed by 32 weeks of gestation. Okay, because so problem with student है वो 32 mug up कर लिया है. No, yes, I agree with all of you. If all the weeks are given to you 20, 26, 32, then 32 is the answer. Okay, but if the options are 24, 32 intrapartum, then intrapartum becomes the answer, and then immediate postpartum is in the option, then that will become the answer. Okay, and that is why in heart disease patient, immediate postpartum we gave immediate postpartum, therefore we gave IV diuretics. Okay, all this point will be repeated day after tomorrow also. Okay, is it clear to all of you? Yes. Okay, so this is about your heart disease patient. About this, then blood ka changes physiological will tell you in the anemia. Is this clear to? Yes, can I get 10 thumbs up? So just remember, cardiac output rises during pregnancy. It starts from first trimester. And maximum is around 28 to 30 weeks. So if 30 weeks the cardiac output is very high, 32 weeks is the danger period. But then the next danger period is during labor, 50%, and the maximum danger period is in the immediate postpartum because of I repeat, what is auto transfusion? The uterus will strongly contract, so mother's blood goes back to the mother. Mother's own blood is coming back to the mother. This is called as auto transfusion. Auto transfusion is seen when immediate postpartum we get auto transfusion. Perfect. Okay, now please pay attention. Yes, auto transfusion when. Okay, now again, no explanation, only I come back to this in a minute. 1 minute, I'm coming back to this. Yes. Okay, now the clotting factors 2, 7, 8, 9, 10 will increase in pregnancy. I'm talking of clotting factors. Okay, 11, 13 decrease in, there's no explanation, mug up. Platelet count also slightly decreases during pregnancy, platelets. Okay, and bleeding time, clotting time remains unchanged during pregnancy. Bleeding time, clotting time remains unchanged during pregnancy. Coming to this in a minute. Okay, yes, so this is the changes in the clotting system. Factors 2, 7, 8, 9, 10 will increase in pregnancy. Fibrinogen is always high in pregnancy, and therefore ESR is always high in pregnancy. Don't bother. 11, 13 platelet count decrease, and bleeding time, clotting time remains unchanged during pregnancy. Okay, is understood to all of you? Yes. Okay, I repeat factors. So this mug up, there's no explanation. 2, 7, 8, 9, 10 increase during pregnancy. 11, 13 decrease, platelet count slightly decrease, and BTCT, bleeding time, clotting time decreases during or remains unchanged. BTCT remains unchanged during pregnancy. Okay, now because the blood supply to all the organs is increased, okay, renal blood flow will increase in pregnancy. So if the renal blood flow increases, even glomerular filtration rate also increases. GFR, this MCQ asked 2-3 years back, what happens to GFR in pregnancy? Increase, decrease, no change. So increase mark करना है. And therefore body का जो भी कचरा होता है, BUN, creat, uric acid is easily flushed off. So body का जो भी कचरा है is easily washed off, and therefore that is less in pregnant patient compared to the non-pregnant patient. So renal blood flow increases during pregnancy, glomerular filtration rate increases, and creatinine clearance therefore is going to increase. Therefore, BUN create uric acid is less in a pregnant patient. Please understand, I have not seen these questions coming in the last 3-4 years, but yes, any of the question can come in the exam. Okay, that what is all are increased except, all are decreased except, like that. Okay, now when we look at the respiratory system, the amount of air which the patient takes, tidal volume increases in pregnancy. Okay, amount of air, because the diaphragm goes up, the residual volume and functional residual capacity, wherever you get the word R, जहां पे भी R आएगा, residual volume and functional residual capacity will decrease in pregnancy. Okay, and and respiratory rate remains unchanged during pregnancy. Very, very important. Common sense. You see so many pregnant ladies around you, walking, talking, coming to shopping center, multiplex. They are not breathing faster. They are breathing like the same rate what we do. Okay. So tidal volume increases, residual volume and functional capacity decreases, and respiratory rate and even vital capacity remains unchanged during pregnancy. Okay, total lung capacity slightly decrease. Okay, total lung capacity slightly will change overall. Okay, but so tidal volume increases, oxygen uptake also increases, residual capacity, residual volume all are going to decrease. Total lung capacity slight decrease, but mainly respiratory rate, vital capacity remains unchanged during pregnancy. Okay, is it clear? So this is no explanation, but you will have to mug up. So I just repeat the three tables which you have to remember. Okay, I repeat the three tables which you have to remember. This is table number 1. Please by heart. 2, 7, 8, 9, 10. Repeat 3 times. 2, 7, 8, 9, 10 increases. 11, 13 platelet count decreases. Very famous MCQ. BTCT unchanged. Just say bleeding time, clotting time remains unchanged. Okay, is it clear to all of you? Yes, a small break. We are going in 5 minutes. Please pay attention. Okay. Now, this table, remember, tidal volume increases, vital capacity, respiratory remains unchanged during pregnancy. And this is simple. Okay, sir, renal blood flow will increase. So glomerular filtration rate will also increase. Creatinine clearance will also increase. And therefore, BUN serum uric acid is going to decrease. Yes. Okay. Yes, and what I told you about the cardiac output is maximum in pregnancy during the cardiac output. This is, yes, the same I told you. Okay, cardiac output is maximum at around 28 to 30 weeks. The cardiac output is maximum during pregnancy. More is in the intrapartum and maximum is in the immediate postpartum. Okay, is it clear to all of you? So these are the important MCQs which could be asked to you. Now, very, very popular and again very famous for your FMG exam, the different colors of the, anybody, normal, liker, anybody, which color, which condition which condition do we get tobacco juice liker? Which condition we get golden color liker? Golden. Okay. So again, these questions may come saffron color liker. Okay, so normal, any idea? Any idea? Okay, yeah. So please pay attention. Amniotic fluid pH 7 to 7.5. And this I will repeat, fetal urine is a major contributor of the liquor amniotic fluid. We'll discuss that. Okay, जो पी, there's a very famous मेरा dialogue, जो पी किया वही पिया, वो क्या है, explain to you. You can go and check out on the YouTube also. But जो what you pee, the same you drink. Don't worry, I'll keep it for the last day. This joke. Fetal urine is a major component of the liquor, and pH is this around 40 weeks. At 40 weeks, the liquor is 800 ml. So now please pay attention. Many times this question has been asked. Okay, 36 weeks is best answer to mark. When is the liquor maximum? 36 weeks, 1000 ml. This was asked around 2 years back also in the FMG exam. Okay, maximum liquor seen at 28 weeks. Then options में दिया था whatever 32, 36 and 40. No, 40 पे drop हो जाता है. By 40 it becomes 800 ml. So please keep all numbers. You don't have to remember. You don't have to remember all numbers. Just remember these two numbers. Okay, and then as the date, what is this? Post datism. When you cross the date, liquor will become further less. Okay, is it clear to all of you? Okay, and this is what it is. If it is meconium, the baby passes meconium, it may indicate fetal distress. May, not always. Very good. Golden color liquor, RH incompatibility. What it is, I will explain to you. Okay, saffron color liquor, post datism. ये सब discuss करेंगे. Today is just like a trailer. You are just getting the names. All these topics. Preterm will be discussed in detail. Abruption will be discussed. Very good. Tobacco juice, IUFD. And pus in chorioamnitis. Okay, normal lichal, straw color. Okay, this is understood to all of you. So all these questions may be asked to you. These are simple one-liners, and please don't make a mistake in this. All of you should get your all your marks correct because these are very simple things. Okay, the last thing in this topic. Okay, so as I repeat from the starting, placenta variation, one photo, accenturate lobe, all that may be asked to you. Vasa previa, very important. Umbilical cord, kani pushenge, this liquor volumes definitely asked to you, and color of the liquor, and and I'm coming to this in a minute, and the physiological changes. Definitely one question may be asked. Okay, so these are the various physiological changes per question. Okay, the last part in this, please pay attention. This we are going to discuss in the upcoming class. Don't worry. Okay, plasma volume, all that. Okay, yes. Now, what are the signs in early pregnancy? Again, only for MCQ purpose. Yes, fetal urine is the major component of liquor, beta, liquor. Okay, that when you look at the amniotic fluid, the fetal urine is the major component. Okay, fetal urine is going to contribute maximally to the amniotic fluid. So amniotic fluid is mainly containing what? Fetal urine. Okay, Benji. Okay, yes. Now please pay attention. And colors of the liquor. Now, anybody What is, so again the last part, these are all very very theoretical, practically you don't we hardly see them, but only for MCQ. What is Osiander sign? What is Osiander sign? So in early pregnancy, when I do a PV examination, there are pulsations in the lateral fornix. Okay. No, beta, Monali, we are going to that. Okay. So pulsations in the lateral fornix, these are the pulsations of the uterine artery. Okay. Now blood supply to all the organ is increased. So even the vagina will become bluish in color. Okay. Vagina will become bluish in color. What is it called as, Monali? Okay. Bluish color of the vagina, Jacquemer sign or Chadwick sign. Okay, dusky color you or this. Okay, yeah. Okay, Jacquemer sign or Chadwick sign. Now all of you please pay attention, because if you don't become a gynac you will not get a chance to do a PV examination. Okay, so a gynac patient, matlab non-pregnant patient, the cervix is like the tip of the nose. So all of you please press the tip of the nose, it is firm. This is how the gynac patient cervix will feel like. And pregnancy, the cervix feels like the lips, soft. So for most of us, lips are soft compared to the tip of the nose. Unless if you're very unlucky, it will be other way around. If you're unlucky, then your nose will be soft and lips will be firm. Otherwise, for most of us, the lips are soft and the nose is slightly firm. So that is, if your lips are soft, it is good. So it is good L sign. Thokotal. That's how you remember. I repeat, if the lips are soft, it is good, isn't it? Lips soft, good. That is your good L sign. Good L sign matlab good. Good L matlab what? Good. Good matlab what? Lips are soft. Okay. Lips are soft is good. Okay. And in early pregnancy, by manual examination, your fingers will approximate, that is the Hagar sign. Okay. So please understand, ye again, one of them may come. Please pay attention first of all. The middle column you don't have to remember, because all are there between 6 to 8 weeks, but any of them can come in the MCQ exam. Again I repeat, these were MCQs 5 years back, 5-7 years back, ऐसे एक एक क्वेश्चन आते थे. Last 3-4 years this question has not come. Okay, so all of you look on the board, but it is mug up that Jacquemer sign or Chadwick sign, the vagina will become bluish in color because of local vascular congestion. Osiander sign, it is pulsations in the lateral fornices. Okay, mainly in pregnancy, may be seen in PID. Good L sign, I told you, cervix will become soft. Cervix will become soft is good L's. Okay, Hagar's sign, abdominal and vaginal fingers will oppose, and the Palmer's, I'll explain to you what is Palmer's sign also. Regular and rhythmic contraction during the bimanual examination. But the first paper, all are in the same time. Then you can see this. Okay, 4. So this. Okay, so cervix being soft is the 6 weeks. Then baki sub 8 weeks, 8 weeks, 6 weeks, like that. So it's as a question which is first to appear and as a large. Okay, so रेगुलर एंथेरेमिक कॉन्ट्रैक्शन ड्यूरिंग बायमल एग्जामिनेशन. नाउ इसमें सबसे जो वर्जिन एमसीक्यू कौन सा है? वर्जिन एमसीक्यू इज इट पिस्का केक साइन. नाउ ऑल ऑफ यू टेल मी, आई एक्सप्लेन टू यू फर्स्ट. एंड पिस्का केक साइन seen in फंडल और मिड लाइन इम्प्लांटेशन अगर हुआ है, मतलब फंडल एरिया में, लोअर डाउन सर्वाइकल इम्प्लांटेशन या लैटरल implantation. Anybody? Piscatic sign is seen in. Piscatic sign is seen in ectopic pregnancy, fundal implantation, cervical implantation, lateral implantation. वेरी गुड. सो ये बहुत 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 स्टूपिड है. नो बडी डज इट, बट जस्ट टू टेल यू दैट स्टार्टिंग में if the pregnancy is happening and if it is a lateral implantation, okay, if the implantation is say on one side laterally, then when I do the PV, what will happen is this part of the uterus will appear bigger. Okay, when I do a PV examination, this side of the uterus will appear slightly bigger because embryo wahan pe implanted hai, and this side of the uterus will appear like a normal or smaller. So basically what it is like a asymmetrical uterine enlargement, okay, seen in lateral. But common sense, all of you know, बाद में pregnancy is an example of symmetrical uterine enlargement. So 10 weeks, 20 weeks, 30 weeks, 40 weeks, then uterus is always going to be symmetrically enlarged. Okay, so बाद में always वो starting में वो embryo बाद में यहाँ से वो यहाँ पे आ जाता है, and finally it is going to be a symmetrical enlargement of the uterus only. Okay, but only for practical purposes that you can see this Piscatic sign, asymmetrical enlargement of the uterus seen in lateral implantation. Okay, so Goodell's sign was asked in the past, cervical softening. Piscatic sign is a virgin MCQ seen in lateral implantation. Okay, Baki Osiander I think has been asked one time, pulsation lateral fornices. So as such anything could be asked to you, but Piscatic is the most likely to come in the future exam, lateral implantation virgin MCQ. Okay, so all these questions may be asked to you in our exam, and we need to keep in mind about this MCQ because it may come. Okay, so very quickly whatever we have, so this one table, please remember the different colors of the liker. Just remember that 36 to this is very very important, these two numbers. Please keep in mind about the 36 to 40 weeks wala liker, 36 to 38 weeks 1000 and 40 weeks per 800 ml, and colors of the liker please keep in mind. And physiological changes, one question may come. Placenta, one question may come. So again 2-3 questions are discussed in our morning session. Okay, we will just yeah. Okay, so with all this we finish our first session. It is 11:10. Small break for 10 to 12 minutes, and when we come, I'll just tell you the order kya hai. When we come back, we are going to discuss the normal labor. See, normal labor steps I'll explain to you in detail. Okay, what are the movements, the cardinal movements in labor, but उसमें से MCQ इतना नहीं आता है. And most important, active management third stage labor, what it is, all that extremely important. 100% questions are going to come on this. So normal labor and active management third stage labor will be discussed in 1 hour, and we start with the very important malpresentations, the breech and the face and the transfer, whatever we can finish today, and remaining we continue tomorrow. Okay, so please come back on time. 10 to 12 minutes break, 12 minutes break, and then we meet sharp in 11:27. Okay, so break for small 10-12 minutes and let us come back on time. Okay. Hello, hello, hello. So, am I visible to all, audible to all? Okay, are we back now live? Yes. Yes. So, all okay? Are we ready? Yes. Okay. So now beginning on to the so this whatever we discussed in the morning half, 1 to 2 MCQs may come, something to do with the physiological changes may come, something to do with the placenta and its variation may come questions. Okay. Now normal labor hardly ever asked, but I will teach you anyways. Important maneuvers and the important MCQs. Active management most important, malpresentation the most important. Now, before we begin, please understand this. Most of the time it is a so what are the stages of labor? Okay, what are the stages of labor? Anybody? First stage, second stage, third stage, fourth stage. What is first stage? What is first stage? Okay, yes. So from the onset of pain till full dilatation. From the onset of true labor pains till full dilatation matlab 10 centimeter cervical dilatation. Okay, so cervix is dilating till 10 centimeters. So from contraction start or the pain start, very good, till full dilatation 10 centimeter. What is the second stage of labor? From full dilatation till the whole baby delivery. Baby delivery is called as the second stage. The after baby delivery till the placental delivery is the third stage. And fourth stage is what? Very, very important. 1 hour. 1 hour observation period. 1 hour observation period in the postpartum. Okay, 1 hour you observe the patient in the postpartum period after placental delivery. 1 hour observation postpartum. That is the fourth stage of labor. Now, virgin MCQ. After placental delivery, sometimes the mother gets shivering. I repeat, after placental delivery, sometimes the mother gets shivering. Exact reason for this is not known. This is called as physiological chills. Okay, this is called as physiological chills of pregnancy, or physiological chills. Okay, I repeat, after placental delivery, sometimes the mother gets shivering. Exact reason is not known. This is called as physiological chills. Okay, so they can ask you the virgin MCQ. Physiological chills is seen in which stage of labor? First, second, third, fourth. What's the answer, all of you? If the MCQ is physiological chills is seen in which stage of labor? 1, 2, 3, 4. What's the answer? Yes, physiological chills in the fourth stage of labor. Okay, fourth stage. Very good. So not the third stage, but after placental delivery. It's always after placental delivery. So physiological chills is seen in the fourth stage of labor. Okay, is it clear to all of you? Yes, not third. Okay, after placental delivery, that means fourth stage. Okay, yes. Now what is, if I ask you the MCQ, what, so most of the time it is the baby's head which will come out. Okay, the head delivery will take place first. Okay, most of the time it's going to be like this, the head is down. Okay, so kefal or vertex, we'll discuss all that in vertex, what happens and all that. But if I ask you, what is the most common malpresentation? What is the answer? What is the most common malpresentation? Anybody? Very. And if I ask you, what is the most common malposition? Now, what is the answer? Most common malpresentation is what? Most common malposition is what? So what is malposition? Yes. So no. Okay. So please understand this, that malpresentation, very good. We are talking about the presenting part. What is the meaning of presenting part? Or we are talking about the presentation, the part of the baby which occupies the lower pole. Okay, the part of the baby which occupies the lower pole or down. Okay, that is called as the presentation. Okay, and what I feel on PV first is called as the presenting part. Okay, what I feel on PV is called as the presenting part. Okay, so please pay attention, this very important. Students do not know this, that what is the difference between malpresentation and malposition. I repeat, the part of the baby which occupies the lower pole, we call it as presentation, and what I feel on PV is the presenting part. So very good. The answer to this MCQ is breech. Most common malpresentation is breech, which I will discuss after some time. That sir, if it is not head, head ke badle, instead of head, the buttocks are going to come down. That is the breech. Types of breech, all that we'll discuss, footling, all that. So here the baby's buttocks and the lower limb are going to, I feel, the first. Okay, or they will occupy the lower part. So breech is the most common malpresentation. Okay, but when I use the word malposition, I am talking about the position of occiput. Occiput का position का बात हो रहा है. So it is vertex only. It is head delivery. Okay, it is a vertex or a head delivery only. It is a vertex or a head delivery only. Yes, very good, Chitranjan. But in vertex or in the head, OA, occipito anterior. We'll discuss all. Okay, occipito anterior or occipito transverse. Okay, at the beginning of labor, I will clarify that also. Occipito anterior or occipito transverse is considered normal. Very good, Poppy. Okay, so occipito anterior agar normal hai, then occipito posterior will be considered as abnormal, because 90%. So remember, vertex can be OA or OP. Okay, vertex can be OA or OP. So 90% of the time it is OA. OA or OT also, occipito anterior or occipito transverse. That is okay. Okay, so basically occipito is either anterior or transverse. We'll discuss that. That is considered normal. So occipito posterior is seen in 10% of the cases, which then becomes the malposition. Is it clear to all of you? So I will show you with picture diagram. Don't worry that when it is occipito posterior, head only comes out first. So OP may remember, when it's OP, it is a head delivery. Is it clear to all of you? In OP, in occipito posterior, it is a head delivery only. Head will only come out first. Okay, head will only come out first. Okay, head will only come out first. But instead of occiput being anterior, occiput is posterior. Occiput is posterior. Is this understood to all of you? Okay, so So this is a vertex. So this is mal position. What is the meaning of mal position? We are looking at the position of occiput. Again, usme LOP, ROP. So ROP is more common. We'll discuss all that in the ending of the today lecture or tomorrow lecture. Don't worry. Okay. Is it clear to all of you? Mal position will mostly go to tomorrow. Okay, is it clear? So don't worry, all these points will be repeated. अभी के लिए खाली दो MCQ याद रखेंगे. Please keep in mind, breech is the most common mal presentation and occipito-posterior is the most common mal position. Yes, can I get 5 thumbs up? Okay, when I say, just remember when I use the word mal position, we're talking of position of the occiput. So instead of occiput being anterior, occiput is posterior, but it's a head delivery only. Okay, presenting part is vertex only. Presentation में कोई फर्क नहीं, it is a vertex presentation. ओके यहाँ पे पूरा माल प्रेजेंटेशन मतलब पूरा प्रेजेंटेशन ही अलग है. ओके the whole presenting part is only different. Okay, yes. So now all of you pay attention that when it is okay, now again this three values we are supposed to remember. I'll also repeat this also in the upcoming lecture also, that when it is a complete flexion of the baby's head, we get a vertex presentation, suboccipitobregmatic 9.5 centimeter. Again, there is no explanation. Please understand, you have to mug up this table, but you don't have to mug up the whole table. Only the three values you have to mug up. Suboccipitobregmatic is the diameter in your vertex presentation, 9.5 centimeter. What you have to by heart? Mento vertical 14 centimeter. I'll repeat this two more times. This you get in brow. What is brow? All that I'll discuss. Don't worry. When the head is midway, if it's completely flexed, see, if I am the baby, you are the doctor. If my head is completely flexed, that means the chin and the sternum are meeting, then you will feel my head. If it's completely extended, you will feel my face. All this I'm going to teach you with picture diagram. But if it's midway, then you get the brow. Okay, partial extension would lead to brow presentation and mento vertical 14 centimeter. And submentobregmatic again 9.5, same as the first figure, that is complete extension, we get face. So complete flexion is vertex, complete extension is face, midway is brow. Okay, 9.5, 14, 9.5. Rest of the whole table we need not remember. There's no need to remember the whole table. Just remember these two things. Okay, so just remember number 1, number 4 and number 6. Don't worry, we're going to repeat all this in the upcoming lectures also. Okay, now what is the difference here? So this is it. Okay, so when it's a complete flexion, okay, suboccipitobregmatic diameter 9.5 centimeter and mento-vertical from mentum till the highest point brow mein hoga 14 centimeter. Please by heart this number. This has been asked in the exam. Mento-vertical diameter is how much? 14 centimeter by heart. No explanation. Okay. Is it clear to all of you? Yes. Now please pay attention. Yeah, we'll come back to this in a minute. Okay. Now please pay attention, all of you. Okay. How do I differentiate between true labor pain and false labor pain? What is true labor pain? What is false labor pain? Again, only for your difference we should know. Okay. And yes. Okay. So true labor pain, along with uterus, the cervix has to dilate. So when the cervix is dilating, it's a true labor pain, and the frequency of contraction keeps on increasing. The duration of contraction is also more. That's first the contraction is only lasting for 5 seconds, then 10 seconds, 15 seconds, 30 seconds. Okay, so the contractions occur at regular interval. Intensity will increase, interval between them will shorten, and cervix will mainly dilate. That is the most important point. And false labor means contraction occurs at irregular intervals. Intervals remain very long and mainly cervix does not dilate. Okay, so again, this nobody is going to ask you, just to understand the topic. Okay, now all of you please pay attention. What are the cardinal movements of labor and what we need to keep in mind? Okay, so okay, so now all of you please look on the board. All of you please look on the board. The outer circle. Now all of you are the doctors, and if we are doing the PV examination, lifelong remember, starting from now till the end of my lecture, if the mother is, imagine the mother lying down in the labor ward, and you are doing a PV from here. Whatever is towards the ceiling. Okay, so the mother is lying down here, whatever is towards the ceiling or 12 o'clock or pubic symphysis, this is called pubic, I'm writing PS, pubic symphysis. All this we called as anterior. I repeat, whatever is towards the ceiling of the labor ward. Okay, so imagine labor ward, imagine mother lying down on the labor ward bed and you are doing the PV examination. Okay, and right and left is in relation to mother. Okay, so this is the mother's right side, this is the mother's left side. Do you agree with me or not? This is the mother's right side, this is the mother's left side. Okay, so right and left is in relation to the mother, matlab mother ka right, mother ka left, and anterior posterior is in relation to 12 o'clock and 6 o'clock. So whatever is towards the pubic symphysis, PS is pubic symphysis, or 12 o'clock or ceiling, and whatever is at 6 o'clock or towards the floor, this will be called as posterior. Understood? Easy. Whatever is towards 6 o'clock or towards the sacrum, यहाँ पे होता है sacrum. Okay, so I am writing S, sacrum का S, या 6 o'clock का clock का 6, या towards the floor. Is it clear? Okay, so towards the ceiling is called anterior. Yes, can I get 5 thumbs up? And towards the floor is called posterior. Okay, so ये आउटर सर्कल है. अभी इसके अंदर one more circle we will draw, which is the baby's head. So the outer circle is the pelvis. Now this is the baby's head. Okay, this inner circle which I have drawn, this inner circle which I am drawn is the baby's head. Okay, now when I say, so this is the baby's head, imagine this is the baby's head. Okay, and suppose if I say that the occiput is here, occiput is here, or even here, all this area mein, matlab in your clock hand 12 o'clock, 1 o'clock, 2 o'clock, all that is LOA, left occipito anterior here. Okay, okay, is this understood to all of you? This will be called as left occipito transverse. Do you agree with me? So when the occiput, so the black circle is the baby's head. All this nobody is going to ask you. Only for my love for the subject I am teaching you. But when the occiput, अगर ये 12 o'clock है, तो ये आपका हो जाएगा 3 o'clock. ये 6 o'clock है, ये आपका हो जाएगा 9 o'clock. Yes, do you agree with me? 12, 3, 6, 9. So when the occiput is somewhere over here, we call it as LOA. When the occiput is at 3 o'clock, we call it as LOT. Is this understood to all of you? Okay, so tomorrow morning, same diagram I will draw. Same diagram I will draw, but that time I will put the occiput mark over here. Anybody, ये क्या हो जाएगा if the occiput is here, somewhere between 6 o'clock and 9 o'clock? ये क्या है? If I ask you this or this, 6 मतलब somewhere चलो 7, 8. somewhere between 7 o'clock, 8 o'clock in your clock watch. What is this called as? Yes, anybody? Yes, excellent, Kinnai, LSD. Okay, sir, this is occipito posterior because occiput is towards the sacrum, 6 o'clock. Okay, it is more towards the 6 o'clock, and this is on the right side, so it is ROP. Even if you get it correct, even if you told me OP, it is excellent, superb. All of you take a bow. Okay, so don't worry, all this will be repeated. Okay, sir, when the occiput is towards the sacrum or 6 o'clock, 7 o'clock, 8 o'clock, we call it as OP. It could be this also. This will be LOP, but this is a right side, so this is right side, ROP. And when the occiput is over here, 2 o'clock in your clock hand, 2 o'clock, it is LOA. Okay, now please pay attention. Please pay attention. The golden rule of the pelvis is, okay, so for 2 minutes, forget this. This we'll discuss tomorrow. Hmm. Hmm. Okay, now all of you pay attention. The golden rule of the pelvis is what? That vaginal delivery will only take place if the occiput is in the midline. That means for vaginal delivery, for VD is my short form for vaginal delivery. For VD to happen, for vaginal delivery to happen, where should be the occiput? Anybody? Occiput should be in the midline. That means, sir, either occiput should be at 12 o'clock or 6 o'clock. Is this understood to all of you? Yes. So for vaginal delivery to take place, occiput should be either be at 12 o'clock or occiput should either be at 6 o'clock. Then only the vaginal. This is a rule. This is a rule. Okay. So now all of you please pay attention. Labor begins with the descent is a continuous process. Head is coming down, coming down, coming down. Labor begins with the when the labor begins, what will happen? The baby is coming down, coming down, coming down, and baby's head will touch the pelvic floor. Okay, now please pay attention. LOA is considered normal, and Datta textbook mentioned that LOT is the common at the beginning of labor. So I will teach you LOT, but LOA also same thing happens. Okay, everything is the same between LOA, LOT. Mechanism of labor is the same. Okay, so the baby's head, the bipelvic diameter will cross the pelvic inlet. That is called engagement. The head has entered the pelvis. Engagement. Okay. The baby's head enters the pelvic inlet. That is engagement. Now, anybody, what will happen? I told you, okay, for the delivery to happen, occiput should come at 12 o'clock. So when the occiput is over here, this rotation, can anybody tell me what do I call this movement which is taking from year to year? From year to year or from year to year, both these movements are called as what? Anybody? Okay, either sir, the occiput was at 3 o'clock. Occiput was at 3 o'clock and occiput now came to 12 o'clock. Very good. This movement is called as it is happening inside the pelvis. So this is called as internal rotation. MCQ virgin. Internal rotation takes place at the level of what? Internal rotation takes place at the level of levator ani. Levator ani muscle or the pelvic floor. The levator, I repeat, the internal rotation takes place at the level of levator and our pelvic floor. Anybody, this is very very difficult virgin MCQ. पहले याद रखो, ये भी virgin MCQ है. Levator and internal rotation takes the level of levator and our pelvic floor. This is because of what? Okay, so I'm teaching you the highest level of gynecology. Nobody will ask you all these points, is my guarantee. Okay. So the levator ani is going to the rotation takes place at the level of, okay, so internal rotation takes place at the level of levator ani muscle or the pelvic floor. Some say just above the pelvic floor, but at the pelvic floor. This happens because of the Hart's rule. What is this Hart's rule? H-A-R-T. Hart's rule. Hart's rule is, okay, sir, because of the orientation of the levator ani muscle. How is the orientation? So levator ani muscle fibers run downwards, backwards, medially. Okay, downwards, backwards, medially. So levator ani muscle, when they contract and release, धीरे 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 occiput पीछे से, मतलब 9 o'clock से आगे की तरफ आता है. This is called as the Hart's rule. मतलब Hart's rule says that gutter arrangement of the muscle fiber. Okay, muscle fiber arrangement is how of the levator ani muscle, downwards, backwards, and medially. Okay, is this understood to all of you? Okay, is this understood to all of you? So I repeat, this is that the levator ani muscle fibers are running downwards, backwards, and medially. Downwards, backwards, medially, and this is called as Hart's rule. ये कोई नहीं पूछेगा आपको, खाली याद रखना है कि internal rotation takes place at the level of levator ani muscle because of the Hart's rule. Is this clear to all of you? Now क्या होगा कि now the occiput came at, occiput अभी कहां पे आ गया, 12 o'clock आ गया. Now baby's head is flexed, isn't it? Baby's head is flexed, so delivery will take place by extension. Okay, so head delivery by extension, very very important. Okay, so पहले engagement, descent, internal rotation, head delivery by extension. So all of you please pay attention. I'm writing this also for you in a minute so that you understand the whole sequence of event, but you should also know this. Okay, okay, that point number 1, engagement means pelvic, the baby's head enters the pelvis. Then what will happen after engagement? The baby's head will touch the pelvic floor, and then there is internal rotation. Anybody, internal rotation takes place because of the what? Hart's rule. Okay. Now क्या होता है? Crowning. What is crowning? Okay, sir, the baby head is visible at the introitus. Okay, the baby head is visible at the introitus. The scalp, this baby's scalp is seen at the introitus, and it remains there even after the contraction is over. वरना पहले क्या होता है? Head is coming down. With contraction, head slightly goes up, comes down, goes up. But when finally the head is very much down, scalp will be visible. Then what will happen? Anybody? Head delivery. How will the head delivery take place? By extension. यहाँ पे आपको Virgin MCQ 2027 MCQ. Okay, 2027 MCQ. All of you please pay attention. Ridgen maneuver. Yeah, I'm repeating. Everything will be repeated, beta. I mean, pay attention. Everything will be repeated. Ridgen maneuver is for Ridson maneuver is for? Anybody? Breech delivery 2027 Virgin MCQ. With figure, with diagram I'm showing you. Ridson maneuver is done for breech delivery, shoulder delivery, head delivery, placental delivery. वेरी गुड. सो इतना ही याद रखना है कि रिडसन मनूवर इज फॉर हेड डिलीवरी. दैट्स इट. With picture, with diagram I'm showing you, but Ridson maneuver is for head delivery. Now please understand, nothing special, nothing great in this Ridson maneuver. Okay, I told you baby's head is flexed and the delivery will take place by extension. Extension has to extension will take place, extension has to take place, but I want a gradual extension. When there is a, yes, very good, Bilal, when there is a fatak se extension, there can be lot of tear. So one hand I give perineal support, that is okay, but you keep on maintaining the flexion of the baby's head so that there is a gradual extension. Okay, so clap if all of you clap if you feel happy. This is the Ridson maneuver for the first time ever. Of course, a virgin MCQ never ever asked, okay sir, we are, this hand is giving the perineal support and this is, we are doing the head delivery. Head delivery will take place by extension, but how? Head delivery by gradual extension. Dheere dheere. Let the extension happen gradually. Okay, so this is the Ridson maneuver. Okay, is it clear? I repeat, what is Ridson maneuver? Head delivery by gradual extension. Okay, now head delivery हो गया. Now please understand this head delivery by extension. Extension के लिए हमें कौन सा यूज करना है? Ridson maneuver. Now because the shoulder, because the head has undergone so much rotation, because the head has gone so much rotation from year to year, there is a twist on the baby's neck. So head is now out. So there's going to be untwisting of the baby's neck. This is called as what? Untwisting of the neck, which is called as what? Anybody? Virgin MCQ. Untwisting of neck. क्या बोलते हैं इसको? Restitution. Untwisting of the neck, which is called as restitution. Very good. Now the shoulder has to rotate. So actually remember, dear student, it is internal rotation of shoulders, but this will look like the external rotation of the fetal head. Why now external? Because now the head is already out. Head is out of the vagina. इसलिए हम उसको बोलते हैं external rotation of the head. Okay, so internal rotation of shoulder, which is then looking like external rotation of the fetal head. उसके बाद, so untwisting of the neck, and then there is the delivery of the shoulder, posterior shoulder first, then delivery of the anterior shoulder. So then there is the shoulder delivery, shoulder ka delivery, and rest of the, then the baby is delivered by lateral flexion. Nobody is going to ask you all this. ये सब में से एक ही क्वेश्चन, मतलब एक बार आया है कि internal rotation takes place where? At the level of pelvic floor, and Ridson maneuver is for what? Head delivery. uh, are the questions expected. So all of you please pay attention. Of course I am repeating everything. Okay, Imad, please pay attention. Okay, so point number one, that sir, these are called as the cardinal movements of labor. Engagement. What is the meaning of engagement? Sir, when the biparietal diameter passes through the pelvic inlet, it is called, मतलब head pelvic के अंदर घुस गया है. Okay, when the biparietal diameter BPD, biparietal diameter 9, okay, passes through the pelvic inlet, we call it as engagement. Engagement के बाद क्या होता है? Descent is of course happening. What will happen, all of you? Chalo, tell me. Internal rotation will, then the baby's head will touch the pelvic floor. So internal rotation will take place at what level? At the level of levator ani muscle, because of Hart's rule. Crowning matlab the baby's head is now seen. This much part is seen at the vulval outlet, and its head remains there, does not go back even after the contraction is over. And then what will happen? Head delivery will take place by extension. यहाँ पे which maneuver we will do? चलो type in the chat box. Head delivery by extension, which maneuver we will do? Okay, Ridgen maneuver will be done for head delivery by extension. Now neck पे twist है, so untwisting of the neck, which is called as restitution. Then it is internal rotation of shoulder, which will look like external rotation of fetal head. Then the delivery of the shoulder and rest of the trunk. Is this understood to all of you? Thoko tali. Okay. Okay, so engagement, descent is a continuous process. Internal rotation will take place. Head delivery by extension and twisting of the neck. External rotation of the head, which is actually internal rotation of shoulders, and then delivery of the shoulder and then trunk. Okay, and first virgin based MC, first image based MCQ, but this one is your Ridzen maneuver. Basically, it is head delivery by gradually extension taking place. Okay. Yes, all this has never been asked to you. What is going to be asked to you is now. Okay, what is going to be asked to you now is now. Okay, is it clear to all of you? So normal labor questions have never been asked to you. In this, hardly ever the question is asked is this, can be asked is Ridzen maneuver. This picture could be shown to you, and internal rotation ka levator ani muscle fiber downwards, backwards, medially, which even your anatomy teacher will teach you. Now comes the most important part, active. Is it clear to all of you? So I repeat, this movement, okay, this occiput rotating from here or here to here, this is our internal rotation. Okay, that is internal rotation. Okay, now please pay attention. Okay, please pay attention. Extremely important. AMTSL. Okay, anybody, what is active? पहले AMTSL, active management third stage labor. Yeah, I wish it was so easy, but that's good. Okay, yes, anybody, what is, पहले ये क्या है? Very important MCQ. But anybody, why we should do this? Why to do AMTSL? Active management third stage labor. Yes. So active management third stage labor is done to decrease the blood loss and decrease the PPH. Okay, it is done to decrease the blood loss and decrease the PPH. So if I ask you which patients to do this, very good. So prevention of PPH. Which patients to do this? Which patients to do AMTSL? Very good. All. Each and every patient. Not, yes, Arunjan, not only anemia, hypertension, simple answer all. Because hemorrhage is the most common cause. Okay, please write down all of you. All of you write down this very, very simple basic PSM MCQ. Hemorrhage is the most common cause of maternal mortality. Hemorrhage is the most common cause of maternal mortality in developing countries. Okay, in developing country matlab India, Pakistan, Bangladesh, Nepal, Bhutan, Sri Lanka, all that. Hemorrhage. This hemorrhage is mainly PPH, postpartum hemorrhage, but antepartum hemorrhage can also play a role. Okay, but mainly it is PPH. So hemorrhage is the most common cause of maternal mortality in developing countries. Okay, is it clear to all of you? So in developing countries like your this one. So yes, it's a direct cause. Correct. Anemia is the most common indirect cause. When we say direct cause, most common cause, so it's a direct cause only. Very good. Okay. Yes. So to decrease the blood loss, decrease the PPH, AMTSL should always be done. So for each and every patient, AMTSL should be done. Now please understand what are the three main steps in AMTSL. I will tell you, and then the picture also I will show you. Okay, so point number one. So ये clear हो गया सबको, engagement clear हो गया क्या है? Now please pay attention. Okay, so in AMTSL, active management third stage labor, first I'll tell you the main thing, then I'll tell you the variation. Okay, after baby delivery, after the baby delivery, technical definition within 1 minute. Within 1 minute of baby delivery, anytime within 1 minute, of course, as soon as possible. If I ask you, anybody, what is first drug of choice for AMTSL? Anybody? Methergin, oxytocin, PGE1, PGF2 alpha. Very good. So oxytocin is to be given. It is considered the first drug of choice for doing AMTSL. Picture abhi baki hai mere. Anybody, what dose and what route? What dose I will give and what route also will I give? Oral, IM, IV, subcute, 10 units, 20 units, 40 units, 5 units, 2 units. Yes. So remember, for my induction of labor, I had told you 2.5 to 5 units very slowly. Okay. 2.5 to 5 units very slowly. Okay. Okay. For the PPH actual treatment, PPH actual management, which I'll discuss tomorrow, we give 20 to 40 units IV infusion. And for the no beta, yes, Bilal, so mainly for AMTSL we give intramuscular 10 units, so please by heart this. Okay, so oxytocin has got different doses which I give at different. This is because it is for prevention, we are preventing. Okay, so oxytocin or methergin both can be given, but very good after baby delivery. Oxytocin can also be given. Remember students, methergin can also be given, but oxytocin, as all of you know, is considered the first drug of choice. Okay, how much oxytocin? 10 units IM. Now, okay, oxytocin 10 units IM you give. Now we do control cord traction. We do control cord traction to deliver the placenta. So the logic is that the baby is already out. Baby ke piche piche placenta also comes out, so that the duration and blood loss of third stage of labor is decreased. Instead, the baby is already out and baby ke piche piche the placenta follows, so that the duration and blood loss of the third stage of labor is decreased. So this is giving a parenteral uterotonic agent. This is followed by control cord traction, जिसको भी और एक नाम है, I'll tell you in a minute, to deliver the placenta. And after placental delivery, then we can massage the uterus. Okay, then we can massage the uterus. Okay, so this is the AMTSL के three main components, giving a parenteral uterotonic agent, then the control cord traction to deliver the placenta, and then massage the uterus. Okay, yeah, I'm coming to rapid R. Okay, CCT kya hai, and what's another name for CCT? Anybody? Before that, एक second. Yeah, CCT explain to you. Okay, so now, can I do this? First point, can I do this in twins? Can I do this AMTSL in twins patient? दो बेबीज हैं, तो अगर खाली फर्स्ट बेबी हुआ है, या वी आर गोइंग टू डिस्कस ऑल दैट. ओके, अगर फर्स्ट बेबी खाली आउट हुआ है, ओके, सो इन ट्विंस नॉट टू डू. कैन आई सेइंग नो? नो. हाँ, वेरी गुड RR. Okay, so point number one, okay, this is a trick MCQ, googly clean bold. Okay, please understand this. All of you are correct that, sir, when there is twins, if we are having twins patient, we will deliver the first baby. But after first baby, because please understand, my logic is to prevent PPH. I want both upper lower segment to contract. Yes, that's why I'm giving 10 units. So after first baby delivery, to make the uterus contract, 2.55 units can be given. But here in AMTSL, we are going to give 10 units. So after delivery of the first baby, do not do AMTSL now. Clear? But yes, sir, then when I will deliver the second baby, abhi koi shak, abhi koi confusion? No, sir. After delivery of the second baby, now I will do AMTSL to be done. Thoko tali. Is it clear? So this is a trick MCQ. Yes, sir, even in twins, AMTSL can be done, but after the delivery of both the babies. Okay, so twins, deliver first baby, do not do AMTSL now, But once the second baby is also out, now yes, AMTSL can be done. Okay, AMTSL, active management third stage labor. Okay, is it clear to all of you? And this is what I was telling you. AMTSL is administration of the uterotonic drugs. Control cord traction, CCT, somebody asked me, controlled cord traction, picture bhi dikhayenge. And then massage after the delivery of the placenta reduces the incidence of PPH by almost 60%. Number you need not remember, but remember this. Okay, so this CCT, control cord traction. And anybody, what is another name for this CCT? Brand Andrews maneuver, BRANDT, Brand Andrews. So all these points nobody will teach you. All these are virgin MCQs likely to be coming in the future exam. Okay, CCT ka another name is Brand Andrews maneuver, and all of you please clap and you feel happy. I'll show you the actual steps in a minute. And this is the picture, virgin image based MCQ. All of you can see, never push. Okay, dono side pe push nahi karna hai, otherwise there'll be inversion. So this is giving a push towards the mother's head, and here with the artery for this umbilical cord. Okay, you can clearly make out. Okay, some cord like structure is coming out, and with the artery forceps you keep on doing control, rotate. So this will come like this, and this you put like this. Okay, do not simultaneously squeeze the uterus now. Okay, there can be inversion. So control cord traction to deliver the placenta. Okay, so what is the picture showing you? Control cord traction, also called as Brand Andrews maneuver. Okay, so all the difficult MCQs also I have shown you. Now kya hai? Basically wahi hai. Okay, and yes, somebody was asking me, yes, always remember the latest guidelines, delayed cord clamping. Okay, except when Benji, okay, so always delayed cord clamping. As long as the baby is very active, crying, it's called active baby, then we can always do delayed cord clamping. But if the baby requires some resuscitation, if the baby has not breathing, then I will immediately cut the cord and give it to the this one. Is it understood to all of you? Okay. So only in those cases we do early cord clamping. Otherwise, always the delayed cord clamping is preferred. Okay. So what is the AMTSL? Sir, you administer a uterotonic drug at the delivery within 1 minute of the baby's birth. The variation I'm telling you in a minute. Okay, within 1 minute of the baby's delivery, I'll show you. Okay, performing AMTSL, you need to palpate the baby's mother's abdomen to rule out the presence of any other baby. समझ में आ गया? If there's one more baby inside, then you hold on. Okay, is it clear? So rule out the presence of any other baby. मतलब twins पहले से पता होता है तो very good, but you palpate and make sure there's no more baby inside, and then begin the procedure by giving 10 units oxytocin IM to the patient. Okay, 10 units of IM. This is followed by clamping the cord, and you will wait for 2 to 3 minutes after the birth of the baby or stopping of the cord pulsations. Is this understood to all of you? So yes, it is a delayed cord clamping which is performed nowadays, and then you perform the control cord traction, also called as Brand Andrews maneuver, and then you will massage the uterus immediately after the delivery till it is firm. Okay, so these are the 3 main steps to be performed. All of you need to keep this in mind and keep this picture of control cord traction in mind. Okay. The last part. Okay, now please understand this 2 main things. So mainly remember within 1 minute of the baby delivery. Okay, that is what I told you to remember. Now variation in this. Okay, so after the baby delivery, now once very difficult in the all India NEET PG and INI-CD, this question had come. ध्यान से सुनेंगे कि when we are doing AMTSL, when we are doing AMTSL, how earliest oxytocin can be given? मतलब that 10 units IM जो देना है, हाँ, within 1 minute बराबर है, within 1 minute is timing, but before earliest, before head delivery, after head delivery, after delivery of the yes, चलो ऑलमोस्ट ऑल क्लीन बोर्ड. ओके, टफ एमसीक्यू है बट अगर आता है तो आफ्टर ए व्हेन वी आर डूइंग एएमटीएसएल हाउ अर्लीएस्ट कैन आई गिव ऑक्सीटोसिन? Okay, so all of you please pay attention. Okay, obviously before head delivery I cannot give, because before head delivery if I give, that is the whole 10 units risk of rupture uterus, because the baby is still inside. Before head delivery the baby is still inside. If I give 10 units, rupture uterus, I told you both upper lower segment can contract. Okay, after head delivery if I give, the shoulder will get stuck, so we have to wait for the shoulders also. shoulder dystocia ho jayega just after the head delivery if I give, and you will give it after the delivery of the anterior shoulder. Way to remember, clap A. So यहाँ पे A है, यहाँ पे भी A है. Okay, so after the delivery of the anterior shoulder, so that is what you will write down over here also, after baby delivery or after the after delivery of the anterior shoulder AA, or after baby delivery within 1 minute. Okay, is this understood to all of you? So this was over here also. All of you look on the board. Okay, the administration of the uterotonic agent is done after the delivery of the anterior shoulder. Okay, or at the time of delivery of the anterior shoulder, or afterwards within 1 minute. Okay, so the whole the दोनों याद रखेंगे. Routinely we wait for within 1 minute we give, and remember 10 units oxytocin IM, and we go for a delayed cord clamping and then control contraction massage. Is this clear to all of you? Okay, can I get 5 thumbs up if you've liked the virgin M? Okay, under the shoulder or afterwards within 1 minute. Okay. Yes. Okay, and then control cord traction and then afterwards massage. Okay, now अभी इसमें भी ध्यान से सुनेंगे. Okay, please remember this. Please remember this, that one student told me, because we get such answers in Viva. One student told me, okay, sir, I will give oxytocin after the baby delivery, after the delivery of the anterior shoulder, on the baby's anterior shoulder. तो ऐसा लेबर वार्ड में इंजेक्शन लेके मत खड़ा रहना और बेबी डिलीवर हो रहा है, हेलो बेबी हाउ आर यू, खटाक से, दैट्स द फर्स्ट इंजेक्शन बेबी गेट्स इन लाइफ, बेबी विल गेट इन इट्स लाइफ. इंजेक्शन इज गिवन टू मदर, टाइमिंग इज इन रिलेशन टू बेबीज एंटीरियर शोल्डर. इज इट क्लियर? वरना स्टूडेंट्स ऑल भी ओवर स्मार्ट होते हैं. ओके, ओवर स्मार्ट स्टूडेंट्स हमें कहते हैं सर प्लीज चिल्ला चिल्ला के एंटीरियर शोल्डर बोलने की जरूरत नहीं है. दिस इज अ मेडिकल जोक, इट वाज सर्कुलेटिंग इन व्हाट्सएप आल्सो 1 year ago. ओके, सर प्लीज चिल्ला चिल्ला के anterior shoulder बोलने की जरूरत नहीं है. It is understood, sir, that the injections are given on deltoid. So obviously when the baby's head is out, I can't give injection on the baby's forehead. So sir, posterior shoulder deliver होगा, anterior shoulder deliver होगा, deltoid दिखेगा, injection ठोक देंगे. Okay, so that is not the reason why I wait for anterior shoulder. Okay, sir, because I want to give injection on deltoid. Okay, so why I wait for anterior shoulder delivery so that I can see the baby's deltoid, and then on the deltoid I will give the injection. Okay, deltoid I will give the injection. Okay, no, that is wrong. Is it clear to all of you? Okay. So please don't say that कि sir we are going to wait for the deltoid का delivery के लिए. तो sir उसमें क्या बड़ा बात है? Okay, there's nothing big about it. Why do you wait for the delivery of the anterior shoulder so that sir injection can be given on the baby's anterior shoulder deltoid? No, injection is given to mother. Timing is in relation to baby's anterior shoulder. Is this understood to all of you? Okay, the timing is in relation to the this one. So before the head delivery, after the head delivery, okay, after the posterior shoulder, after anterior shoulder, but it is after anterior shoulder. Oxytocin is given to the mother. Timing is in relation to baby's anterior shoulder. Okay, so all this you need to keep in mind. इस पे क्वेश्चन आ सकता है स्टेप्स के ऊपर. रिडजन मनोवर पिक्चर आई अगेन शोइंग यू वन मोर टाइम. Okay, head delivery by control extension, and then the shoulder delivery, and then the control cord traction image also called the Brand Andrews maneuver. Absolutely crystal clear. Any confusion, any doubts? Anything not understood, not clear. The last thing, anybody, what could be the anybody AMTSL का सब advantages है blood loss less. What is the only disadvantage? Virgin MCQ. Disadvantage of AMTSL, anybody? So the disadvantage is, okay, sir, the baby is already out and the placenta will also detach and the placenta is also coming out. Okay, placenta is also coming out, but because we have given 10 units, which is of course relatively a higher dose, and both upper as well as lower segment are going to contract. Anybody, what can happen? Yes, so that the cervix can close down. The cervix can close down and the placenta can get trapped inside. Yes. Placenta can get trapped inside or the placenta can get retained inside. It is more of a trapped placenta. Trap the placenta is separated 1 to 2% cases. Okay, just by heart. If there's someone to ask you that the disadvantage of AMTSL is that in 1 to 2% cases there is the placenta can get trapped or retained inside. Okay. Okay, is it clear to all of you? So in 1 to 2% cases, the placenta can get trapped inside or retained inside. This is just by the way, and then you might have to go and do the manual. If this happens, what you do? अगर ये हो गया तो क्या करने का? You'll have to go into manual MROP. Okay, this also could be asked to. The placenta is stuck, then you have to go in manually and remove the placenta. Okay, but placenta can get stuck or trapped inside 1 to 2% cases. So everything discussed, advantage, disadvantage, everything could be asked to you. Okay, is it clear to all of you? Okay. Yes, and the partogram will discuss later on about it. Discussion about it. Okay, so this is your very important thing on. I would not say very important. AMTSL definitely is very important. Mechanism of normal labor is hardly ever asked, and we should know the differences between this one. Okay, the steps of manage the sequence of events in the movement of labor car movement: engagement, descent, rotation, crowning, head delivery, restitution, external rotation, and deliver the shoulders and trunk. Okay, so please keep this in mind. Moving on. Okay. Yeah, so we will now start with a very important topic, and on this surely the questions are coming. And malpresentation. I hope the difference between malpresentation and malposition is clear. I will repeat last time. Okay, sir, malpresentation, malposition, completely different. When I say malpresentation, the presenting part itself is different. Okay, so breach is the most common malpresentation. Anybody, by the way, if I ask you, which is the least common? And malposition means what? We are talking about the position of occiput. So it is occipito-posterior. Occipito-posterior, which is the head delivery, vertex. Okay. Malposition, occipito-posterior. And malpresentation, the most common is breach. And by the way, remember brow. Brow is the least common. Okay, brow is सबसे last. Brow is the least common malpresentation. Okay, is this understood? To very good, Sadhya. Okay, so breach is the most common malpresentation. Breach के बाद आएगा आपका face, and then your transverse line, मतलब shoulder. We'll discuss all that, shoulder, oblique, and then last is the your this. Okay, so brow is the least common. Okay. Yeah. Okay. So just give me a minute. I just load my new presentation and we start onto this breach and face, and then whatever. Just give me a minute. Okay. Yeah, just a second. Once the PPT loads, I'll just switch on to this camera. Just 1 second. Okay. Okay. So just a second. Yes. So now am I visible to all of you? Am I audible to all of you? Yes. Okay. Perfect. So let us begin a very, very important session. And definitely on this, the questions comes for sure. And that is the malpresentation. We already know an idea. What is the meaning of malpresentation? Okay. Now, before we go on to the breech, brow, face, oblique transfers, everything, please keep in mind that there are four different types of pelvis. Details of this pelvis we are not supposed to remember, but gynecoid pelvis is the most common type, or it's like a roomy pelvis, like a female pelvis, the most common, where the walls are divergent, the spine is not prominent, and the what do you call it? The very favorable for delivery, and easily the delivery will take place. Okay, so gynecoid pelvis is the most common variety or type of the pelvis. Okay, next you get is a android pelvis. Anybody, what is android pelvis? Android pelvis is a pelvis where the walls are converging, the spine is prominent, so it is like this heart. Okay, it is like this heart, or basically like a triangle. Yes, like a male. Okay, so like a male type of a pelvis where the spines are prominent, the walls are converging, so this will look like a heart or a triangle. And इसके साथ complication होगा DTA. Anybody, what is DTA? Deep transverse arrest. Actually, second most common is anthropoid. Okay, that's okay. Yeah, so DTA, deep transverse arrest. What is all this deep transverse arrest? Don't worry. Tomorrow morning I will teach you. Fascinating. Don't miss the tomorrow morning part. Mal position. What is DTA? Yes, DTA में बेटा डिलीवर नहीं होगा, DTA is stuck only. Okay, Bilal. So DTA में delivery will take place by LSAS only, deep transverse arrest. Okay, then is the मतलब anthropoid is actually the second most, anthropoid pelvis. Anthropoid pelvis, what you are saying is correct, Bilal. That in anthropoid pelvis is a anterior posterior oval, and this is suitable or favorable for face to pubis delivery. Don't worry, all this will be explained to you tomorrow morning. What is face to pubis? You will only become expert in this. Don't worry, अभी खाली नाम सुनते जाओ. Okay, face to pubis delivery, what it is, how it will happen, when it will take place, all that I will tell you. And the least common type of the, so actually this is number one, this is number two, this is number three, and this is number four. They'll not ask you the sequence, don't worry. Platypaloid pelvis. Platypaloid is clearly the least common type. Okay, platypaloid pelvis. Okay, platypaloid pelvis is the least common type of pelvis. And this is transverse oval. This is transverse oval. Yeah, correct. Very good. Okay, this is transverse oval, and this is associated with face as the presenting part. I am writing face PP. Face PP का मतलब है face as the presenting part. Okay, is it clear to all of you? Now, please, I repeat, android pelvis, complication DTA, anthropoid pelvis, favorable for face to pubis, platypaloid pelvis, face presentation. And yes, that's the least common type. Okay, least common. Okay, is it clear to all of you? Yes. Now please pay attention. Okay, can anybody tell me this face to pubis delivery, and face presentation, is it same or different? Okay, I repeat, is this face to pubis and face, दोनों में वर्ड फेस आ रहा है, is it same or different? And this यहाँ पे क्या है, what is DTA, deep transverse arrest? Okay, so anybody, because even after exam is over, student, even after internship is over, and this deep transverse arrest, DTA and transverse lie same or different? Is a deep transverse arrest. So deep transverse arrest and transverse lie also completely different. Okay, so words are similar. Okay, okay, so face to pubis delivery क्या है, face क्या है, and what is DTA and transfer also you will come to know tomorrow. ध्यान से सुनेंगे, please pay attention. Face presentation means face is the presenting part. I'll show you picture diagram. That means, sir, when I do the PV examination, I will feel the baby ka nose, eyes, malar, mouth, mentum. My finger goes okay, Kinay almost very good, correct, yeah. Okay, so please pay. तो face का मतलब क्या है, all of you please pay attention. Face I'll discuss in some mento antermento. तो sir face में क्या होता है कि I will feel the baby's face with picture diagram I'm showing you. Malar, mentum, nose, mouth. My baby goes inside the finger, baby's mouth. The baby starts sucking my finger. Okay, this question is asked. If you are doing PV, somebody is sucking your finger. Somebody matlab baby. What is it? It is face presentation. ठीक है, is it clear? So face में you will feel the actual face, eyes, nose, mouth, malar, mentum, ये सब feel होता है. But face to pubis delivery, so यहाँ पे face is the presenting part. So this is example of mal presentation. Yes, this is example of mal presentation. Clear? Whereas उसके ऊपर face to pubis delivery is one of the outcome. DTA and face to pubis both. DTA is also seen in occipital posterior or can be seen, and face to pubis delivery is one of the outcomes which I will see in vertex presentation. But only thing, instead of occipital being anterior, occiput is posterior. So vertex OP. Okay, so please understand this, that face to pubis delivery is you see in head delivery. Only thing, instead of head being occiput being anterior, OA, occiput is posterior. So face is facing the pubic symphysis. Tomorrow with picture diagram I will show you. अभी के लिए कितना खाली इतना याद रखो कि therefore this becomes example of mal position. Okay, so vertex OP. So all of you please pay attention. I want all of you. So face to pubis is in vertex OP. It is a head delivery. Okay, face में पूरा presenting part ही अलग है. So all of you pay attention. I want all of you to repeat 5 times. It is like it should be like a reflex action. Moment anybody tells you face to pubis, from your mouth vertex OP word should come out. Like if how anybody says, like if you say Sachin Tendulkar, Virat Kohli, Punit, Bhojani, Shah Rukh Khan, like that, it should be like a reflex, like name, surname. Okay, it's like your name and surname. So face to pubis, vertex OP. Anybody in the world utters the word face to pubis, reflexly from your mouth should come out vertex OP. Is it clear to all of you? I repeat 5 times. All of you have to repeat it. Those who don't repeat it, lifelong will not get this MCQ correct, and those who repeat it will lifelong never make a mistake. Okay, face to pubis आपको किसी ने बोला तो आपको immediately उसके बाद बोलना है vertex OP. Is it clear to all of you? 5 times. Face to pubis. Face to pubis. Okay, face to pubis is vertex OP. That means, sir, it is a head delivery. What do you think? The occiput, instead of being anterior, occiput is posterior. It is called as face to pubis vertex OP. Okay, is this understood to all of you? And don't worry, ये सब हम आपको कल बताएंगे. Okay, now मतलब vertex and all. Okay, so now moving on. So this is just an introduction, you know. So deep transverse arrest is also happening in vertex OP only. Okay, both this. It's also with okay. Yes. So just keep this in mind, and that will be it. Now, please understand this again, the same picture, same thing what I had drawn for all of you. That, sir, the outer circle is the pelvis. Outer circle is the pelvis. This is 12 o'clock. तो यहाँ पे है pubic symphysis. Pubic symphysis. Posteriorly is the sacrum. Anteriorly pubic symphysis. Posteriorly sacrum. Okay, same orientation. Now suppose first I'm discussing face, then we go to breathe. Okay, so suppose if this is the baby's position, if this is the baby's position, that means here is the eyes, here is the nose, here is the mouth, and here is the mentum. Anybody, इसको क्या बोलेंगे हम? Identify the image. What is the presenting part and what is its position? मतलब what is it? Anybody? The first picture. No, Kinnai, that is wrong. This is not face to बेटा. Face to face में क्या होगा? Head होगा. Yes, okay, Kinnai. This is not face to pubis. This is the face is coming on PV first. This is the face presentation. Very good. And this is mento anterior. Okay, don't worry, Kinnai. Tomorrow I will show you this again. Then it will become clear. This is not face to pubis. Face to pubis में face is looking at the pubic symphysis and vertex. What I told you, that's why. Face to pubis में क्या feel होगा? Head. Vertex feel होने वाला है delivery पे. Okay, Kinnai, is it clear? Face to pubis में आपको occiput और head और vertex feel होता है delivery के time पे. Okay, that is the. And now simple, if this is the picture, okay, the baby's face is like this, and here is the eyes, here is the nose, here is the mouth, and here is the mentum. इसको क्या बोलेंगे? Anybody? Everybody? Mento posterior. Simple, easy, ठोको ताली. Okay, the same picture. Mine are both smiley baby. This is slightly a serious baby. Yes, all this, both are face. Very good. Both are face presentation. Both are face presentation, and this is the same picture. Please keep in mind, virgin MCQ, you can clearly see this pubic symphysis. This you can see is the sacrum. You can see the sacrum clearly in the picture. And this is the mentum. This is the mentum. So this becomes the mento anterior. And this is the mentum. So this becomes the mento posterior. Clear to all of you? Now please pay attention that out of the two, the labor is that only in mento anterior vaginal delivery is possible. VD is my short form for vaginal delivery. Mento posterior face, it is a very big diameter, sternobregmatic 18 centimeter, cannot negotiate the pelvis. And mento posterior, the only option is to do LSCS. Otherwise, what will happen is uterus will keep on contracting. prolonged labor, obstructed labor, rupture uterus and the mother will die but the baby will not come out. बात समझ में आ रहा है? Mento posterior, there is no mechanism of labor. There is no mechanism of labor, and therefore for mento posterior we will have to compulsory go and do LSCS only. Is this understood to all of you? Okay, so just remember this. They can ask you as a difficult virgin image MCQ. They can tell you, okay, suppose इसको option देंगे A, इसको option देंगे B, option C both of the above, and option D none of the above. And if the question to all of you is vaginal delivery VD possible in chalo A B C D, VD possible in A B C D. Very good. Vaginal delivery is only possible, sir, in option A, not in both, not in none, sir, because in mento posterior, what will I do? Always LSCS. Why LSCS? There is no mechanism of labor. Okay, there is no mechanism of labor, and therefore mento anterior में vaginal delivery possible. Mento posterior always goes for LSCS. Okay, so just remember, when I feel the baby's face, LR mentum nose mouth, that is face, look at the mentum. Here sir, mentum is towards the pubic symphysis, I call it mento anterior. Here mentum is towards the sacrum, I call it mento posterior. Okay, is it clear to all of you? Yes. So now ये हो गया आपका फेस. एंड डोंट वरी व्हाट इज फेस टू प्यूबिस, ऑल दैट आई विल डिस्कस. एंड मूविंग ऑन टू द breach is the, so this is the, okay, so breach is the most common yeah, so all of you can see over here, okay, when the babies, I told you, when the chin, if the chin is touching the sternum, then baby is in position of flexion, so it will come as vertex. And when the chin is away from the sternum, when the chin is away from the sternum, it is extension, it is extension. So then it is called as a face. That means when I will do the PV, we'll feel the baby's face. Can you see that? यहाँ से हम PV करेंगे तो baby का face feel होगा. Okay, is it clear to all of you? The last thing which you should keep in mind, very difficult MCQ, I told you, okay, face is already, the baby is already in extension, full extension, correct? So this face, I told you that in mento anterior vaginal delivery is possible. I told you mento anterior vaginal delivery is possible. Just remember that I told you head is flexed. So head will take place, head delivery take place by extension. Face will deliver by flexion. FF, face delivery. This face will deliver by flexion. Okay, this in mento anterior, I told in mento anterior only the delivery will take place. Mento posterior, so we are going to deliver by LSCS. Okay, so खाली इतना याद रखेंगे. Don't worry, all these questions are going to ask you that sir, in mento anterior phase, a vaginal delivery will be possible in mento anterior phase, but because sir face is already in position of action, so face will deliver by flexion, mento, and mento posterior, I would directly have to go LSA. There is no mechanism of labor. Okay, no mechanism of labor. Okay, yes. Now all of you, what are the types of breach? What are the types of breach? Anybody? Complete breach, frank breach, footling breach. So anybody? ये वाला first है. What is this type of breach? The first figure. Which type of breach is shown to you in the picture? The first one. This one. This one I am showing you. This baby. Because please see, it is flexion at the hip. It is flexion at the hip and flexion at the knee. दोनों joint flexed है. Flexion at the hip and flexion at the knee. And here it is flexion at the hip, लेकिन extension at the knee. तो क्या है? Okay, Nobel. Okay, so please pay attention. ध्यान से कि when it is both flexion at the hip and flexion at the knee, double flexion, you call it as complete breach. Clap if you feel happy. मैं हूं ना आपको हेल्प करने के लिए कि सर flexion at the hip, extension, yes, correct, extension at the knee. So if the extension at the knee, this is the baby's foot, isn't it? You can see the foot is near the forehead. F near F in F. Frank breach. Okay. Yes, that is why only face is already away. That is why only it will happen beta kinnai. That's why further extension is not possible. Okay. Here it is already in full extension. तो अभी डिलीवरी कैसे होगा? फ्लेक्स होके ही बाहर आएगा ना बेबी. Okay, just remember face delivers by flexion. Okay, when you will actually see the delivery in the labor ward, you will remember. Okay, head will deliver by extension because head is vertex is already in flexion. So head, I told you already, head delivery by extension. By that I explained that Ritson maneuver karenge and I shown you. Okay, so head will deliver by extension. So just remember face will deliver by flexion. Okay, yes. So F near, clap if you feel happy. F F F F F near F in F. समझ में आ गया all of you, Bilal? Okay, yes. Okay, frank foot, baby's foot near forehead, that is frank breech. Okay, and lastly, literally the baby is standing and I can only feel the baby's foot. Okay, if I feel only the baby's foot, that is the footling breech. So basically क्या याद रखना है हमको कि complete breach मतलब flexion at the hip and flexion at the knee joint. Footling breach, flexion at the hip लेकिन extension at the knee. So this is the baby's baby's feet near the forehead. That is the frank breach, and literally the baby is standing. That is the footling breach. Okay, now footling breach, you can imagine, all of you look on the board कि ये सर्विक्स जैसे ही डायलेट हुआ बेबी के लेग्स के बाजू में से. व्हाट इज दिस आई एम ड्रॉइंग? ये क्या हो गया? This baby is not, someone shouldn't miss a baby. You're drawn baby doing susu. Baby is doing urine. No, it's the umbilical cord. There is very high chance. What is cord prolapse? All that we'll discuss. It's a fetal distress. What happened? Okay. So in your footling breech, in breech also, but in the footling breech specifically, there is a chance for the cord to come out. Okay, and therefore footling breech, why I do always LSCS. Okay, sir, in footling breech, don't try vaginal delivery. Okay, is it clear? It's not that vaginal delivery will not take place. Vaginal delivery can take place, but I will avoid. Okay, yes. So footling breech, highest risk of cord prolapse, and therefore we will always deliver by LSCS. Okay. Okay, so complete breech, frank breech, footling breech. Footling breech, very high risk of cord, or high among this highest risk of cord prolapse, and therefore always LACS. Now please understand, I'm writing it down, just always LACS. Why LACS? For fetal safety. Okay, is it clear? Because if there is cord prolapse, the whole cord undergoes spasm. The cord undergoes spasm, there is severe fetal distress, and baby can die. So in cord prolapse, basically I need to deliver as soon as possible. So in cord prolapse, it's an emergency and baby can die. So don't allow that situation only to happen. उसके पहले elective LSCSE कर लो. Is it understood to all of you that in mento posterior we are doing LSCS because labor is not possible only. Here footling breech, labor is possible, but I will not allow labor. Okay. If somebody asks you, doctor, can footling breech deliver? Yes, sir. Footling breech can deliver vaginally, but I will not allow vaginal delivery because there is very high risk of cord prolapse. Okay. And therefore always LSCS. Okay. Is it clear to all of you? Yes. Yes. Okay. Now please pay attention. What is the etiology for breach? Very famous. They are asking you. Why should breach happen? Breach क्यों होता है? What are the main reasons for breach presentation? What are the causes for breach? Very good. Prematurity. What am I saying is that by starting I mean 16 weeks, 18 weeks, 24 weeks, many babies are breached. Then spontaneously the baby will rotate on its own and the breach will become into vertex. Just by the way, anybody that year, sir, at around 20, 24, 25% babies are going to be breech. All these numbers they will not ask you. And most of them will rotate. Anybody at term matlab ke at 36, 37 weeks, how many babies are going to be in breech? Sir, at 37, 38 weeks, or when we call this full term, okay, 96% it is vertex. 96% will be in head down. 3 to 4% cases. Okay. Some books mention 3, some books mention 4. Okay. Is it clear? So this is breach. Okay. So at full term, the incidence of breach is 3 to 4% only. 96% it is head. 95 to 96% head. And 4 मिला के यही 99 हो जाएगा. बाकी जो भी, so head plus breach. Okay. Head plus breach मिला के we are crossing 99%. So बाकी जो भी है face, transverse lie, oblique lie and the brow is all less than 1%. समझ में आ रहा है? Head is there seen in 95 to 96% cases and breach is seen in 3 to 4% cases. So this itself is more than 99%. By the way, head और breach मिला के combination. So बाकी सब जो है face, transverse lie, oblique lie and brow, this is all मिला के less than 1% cases only, or 1%, 1 or less than or equal to 1. Is this understood to all of you? Thoko tali. Okay. Okay, very good. Then uterine anomalies. If there is some uterine anomaly, twins, one baby breach, another baby breach, can both can be breach. Okay. And lastly, if it's a big head, hydrocephalus, a big head can fit the fundus very well. So if it's a big head, hydrocephalus. Okay. So is this understood to all of you? So please understand this picture, keep in mind, complete breach, frank breach, footling breach, and this is the whole. You don't have to remember all the whole 20. Okay, don't remember all 20. Just remember first 4 to 5. Prematurity is the most common cause. Twins, hydrocephalus, liker disorders, very important. Do not forget. Okay, sir, if it's poly, baby will keep on rotating. Oligo, baby is stuck, cannot rotate. So when I this, yes, very good. Short cord also can cause. And your uterine anomalies like your bicornuate uterus, unicornuate uterus, all that can also cause your coming for your breach. Okay, is it clear? So just the first 4. I want you to remember just the first 4. Premature, the most common cause. Twins, liker disorders, don't forget, and uterine anomalies. Just this 4 you remember. Baki ka placenta previa is just an association, and short cord, yes, can happen. Okay, short cord can happen, and placenta previa can also happen. Okay, is it clear to all of you? Yes. So breach का आपका types हो गया, variety हो गया, etiology हो गया. Now coming to the types. Excuse me. For the types of breech delivery. Not talking of the maneuvers, the types of breech delivery. Now, can anybody tell me in breech delivery what is the most difficult part? What is the most difficult part to deliver? Because sir, the buttocks will easily deliver, legs will easily deliver, the head will get stuck because the head is coming afterwards. The head can get stuck, and then the no, yeah, footling is we go for LSCS. Okay, beta, Kritai. So footling breach always LSCS. Now I'm talking of vaginal delivery. When we are doing vaginal delivery in breech, what is the most difficult part to deliver? Okay, what is the most difficult part to deliver in breech? Head, because the head can get stuck. Okay, the head can get stuck, and therefore always for head delivery the doctor should be present. Always for head delivery the doctor should be present. Okay, so please pay attention. There are 3 types of breech delivery. There are 3 types of breech delivery. One is spontaneous breech delivery. It means doctor है ही नहीं. Doctor is sleeping in the room. पर ऐसा नहीं होता है. We are always there. Doctor is always there. Patient does not come only to the labor ward. मतलब के the delivery happens at home. Home delivery, train delivery, bathroom delivery, rickshaw delivery, कहीं पे बाहर delivery before. The whole baby. Doctor was not there only. I'm writing D is cross. Only mother did all the effort. Whole baby बाहर आ गया from the mother's effort only. That is very dangerous. Should not be done. Okay. The best way, all of you pay attention. Virgin MCQ. Okay, the doctor is already present in the labor ward. Doctor is already present in the labor ward, and up to lower limb, buttocks and umbilicus of the baby, it is the maternal effort. It is the maternal effort. That means I am just waiting. मैं just wait कर रहा हूँ कि buttocks आ जाने दो, back आ जाने दो, umbilicus. So it is the maternal effort. And once the delivery of the umbilicus and the umbilical cord is there, then I will actively take over, and then I will deliver the back, the arms, the neck, and then the most difficult part, the after coming head of the breech. This is the doctor, this is the mother effort. बात समझ में आ गया? इसको कहते हैं like 50-50. This is called as assisted breech delivery. Best. And last is where I will only remove one another lower limb, back, buttocks, पूरा baby हम ही निकालेंगे. Total breech extraction. Again, virgin MCQ, nobody is going to ask you this. Please, what do you call? Don't worry, this is not going to be asked to you. But keep in mind, spontaneous breech delivery, entire baby is by maternal effort only. Okay, doctor, I'm writing DR cross 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 cross. Assisted breech delivery, please read. This is considered the best method for vaginal breech delivery. This is considered the best method for vaginal breech delivery. The baby is delivered as far as the umbilicus, and the rest of the baby delivered by assisted maneuvers. This is considered the best method for vaginal breech delivery. And total breech extraction, the entire baby is extracted by the obstetrician only. Okay. Okay, this is considered the best method for vaginal breech delivery, that is your assisted breech delivery. Okay, is it clear what is the meaning of assisted breech delivery? 50-50. Okay, half baby mother effort, half baby doctor effort, and total breech is entire baby, only doctor will only remove. That is mainly done in cases of fetal distress, and this quickly when there is no time. Okay, when there is no time for the baby, when there is no time, then you do the total breech extraction. Okay, so all this I'm going to ask you only just to complete the topic. Okay, now is this understood to all of you? Now all of you pay attention. The names of the maneuver never ever asked. I'll tell you what has been asked. Okay, so these are some, so don't get hassled. Don't get hassled by all these new words. There are 4-5 new words, 5-6 new words, but I'll tell you only which question has been asked. Okay, so when routinely we give a suprapubic pressure, this is called as the crystallar maneuver. Now P for Pinard's, P for popliteal fossa. P for Pinard's, P for popliteal fossa. मतलब के when the baby's lower limb will get arrested, I will put the finger in the baby's popliteal fossa, hook the lower limb out, pull the lower limb out. So that is your Pinard's maneuver. Now, all of you pay attention. The most important part in breech delivery is back should face the doctor. I repeat, the most important part in the breech delivery is that the back should face the doctor. इसका मतलब क्या है कि अगर आप सब लोग डॉक्टर हैं तो बेबी का वी शुड सी द बेबी का बैक. दैट मीन्स आई शुड सी द बेबी का बटक्स, ये लोअर लिम्ब पीछे से, द बैक, द स्पाइन एंड द स्कैप्यूला, ये दिखना चाहिए when the baby is coming out. समझ में आ रहा है? This is called as dorso anterior, isn't it? Dorso मतलब back. So this is good. This is dorso anterior. समझ में आ गया? The back should face the doctor. So doctor should see what? Doctor should see the buttocks, the spine and the scapula. Clear? But अगर baby उल्टा आ रहा है, that means the doctor is seeing the baby ka genitalia first. Okay, whatever, male, female. Then the baby ka the front knee, and then the chest, and then the umbilical cord, and then the umbilicus. This is called as dorso-posterior. समझ में आ गया? So this is not good. मतलब back is towards the mother, isn't it? I am seeing the baby ka front part. That means if you are the doctor, I am the baby, you should see my back. Okay, all of you should see my back. But if it is like this, if you can see my umbilicus and the chest and that is bad, that is dorso posterior. Okay, so then I will have to go and do the Prague's maneuver. Prague's maneuver is dorso posterior. Don't worry, I'm showing you the picture also. Okay, that back should always face the doctor. Just remember, back to face the doctor. This is normal. This is good. Back should normally face the doctor. Is it clear? Dorso posterior breech अगर है तो we'll have to go and do the Prague's maneuver. And lastly, 2027 virgin MCQ, even for NEET PG never asked, can normally inside the mother baby's hands are like this, Superman, but baby's hands can be like this, ये ऐसा position, ये समझ में आ रहा है? Relax ऐसा baby, baby is like this. Okay, तो इसको बोलते हैं न्यूकल आर्म, बिकॉज न्यूकल मतलब नेक, आर्म मतलब आर्म। तो कहने का मतलब यह है, ऑल ऑफ यू पे अटेंशन, एवरीथिंग विल बी रिपीटेड, डोंट वरी। कहने का मतलब यह है कि नॉर्मली द बेबीज हैंड्स आर लाइक दिस इनसाइड द मदर। ओके, बेबीज हैंड्स आर लाइक दिस, सुपरमैन। ओके, एंड बैक हमको दिख रहा है, बट द बेबीज हैंड्स कुड बी लाइक दिस। Okay, like this. Now, how will I come to know? Any idea? We can see the baby ka back. Chalo, tell me, all of you, gold medal, platinum medal. Okay, how? By looking at the baby's back. How? By looking at the baby's back, do I come to know? How? By looking at the baby's back, yes. Do I come to know that the baby's hands are like this or like this? Yes, all of you do this. All of you do this and all of you do this. Okay, तो क्या हो रहा है कि sir, normally the spine and the scapula are parallel. Spine are parallel. But if the scapula border is rotated, that means it is because of, it is telling you it is a nuchal arm or a abducted arm. Okay, so nuchal arm or a abducted arm. Don't worry, this question has never been asked to you, but the answer is correct from the position of scapula. From the scapula position, we will come to know that yes, it is a nuchal arm or a abducted arm. And very good, then I will go and do the, then we go and do the Lawsett's maneuver. Then we go and do the Lawsett's maneuver. Okay. Then we do the Lawsett's. So I repeat, Lawsett's maneuver is done for the nuchal arm or abducted arm, and that I come to know from the scapula position. Okay, so normally scapula, spine, scapula parallel. Okay, so don't worry, all these questions have never been asked to you, but I repeat for the everybody last 5-10 minutes, and we are winding up the session. It's sir, routinely when I give a suprapubic pressure, crystal R maneuver. P for peanuts, P for popliteal fossa, and the lower limb gets arrested. How do I know the lower? What do I do in the in arrested lower limb? Put the finger in the baby popliteal fossa. How the maneuver is to be done? Nobody will ask you. Normally, the back should face the doctor. So dorso anterior. If it's a dorso posterior, we do prax. And if it is a nuchal arm or a abducted arm, this I come to know from the position of the scapula. All of you can do this abduction. Okay, all of you can do the abduction or nuchal arm. Then you know, okay, so normally scapula, spine, scapula parallel. If scapula border is rotated, that is the nuchal arm. Clap if you have learned something new. Okay, clap if you learned something new on a Monday morning. That's sir, if it's a nuchal arm or abducted arm, we will do the Lawsett's maneuver. Okay, now coming to all the maneuvers for the after coming head of the breech, and that is the, what is this image? Anybody? Once in the NEET PG, this MCQ is come. Now here what are we doing? Okay, this is the mother lying down over here, the head, and we are holding the baby by the lower limb and rotating it up, 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 up. This is the Burns-Marshall maneuver. Okay, so Burns-Marshall maneuver. Now all of you please pay attention. First, imagine the baby to be hanging down. The doctor is standing over here. Okay, the doctor is standing over here. Very good. And first, imagine the baby to be hanging down. Okay, so can you tell me where is the back? Isn't it? अगर ये baby हमारा इधर है, so back is facing the doctor, isn't it? Isn't it? If you imagine the baby to be hanging down first, only the head is inside, only the head is, this is the vagina suppose, and the head is inside the vagina and back aisa hai, isn't it? So back is facing the doctor, that is good. Doctor is here. Now what is done in, this is the mother lying down on the labor ward bed. What is done? You hold the baby by the lower limb and rotate it up, 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 up towards the maternal abdomen. So what will happen is that the head will pop out from here. जैसे ये बेबी को ऐसे 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 further यहाँ पे घुमाएंगे. As I rotate the baby further up, 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 up in this direction, isn't the head going to pop out from here? That is the Burns-Marshall maneuver. Is this understood? Please by heart this picture. Burns-Marshall maneuver done for delivering of the after coming head. Rotate the baby. Okay, you will rotate the baby up, 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 up towards the mother's abdomen, so that the head will pop out from below. Okay, very good. Then MSV, Morrissey smelly wheat maneuver. Morrissey smelly wheat, malar flexion. Again, how the maneuver is done, nobody is going to ask you. Only for my love for the subject. Left hand goes inside the vagina, I will give malar flexion. Right hand I will give shoulder traction. तो क्या नाम है? MSV, Morrissey smelly maneuver, malar flexion, shoulder traction. मैं हूं ना ट्रिक, in MS you do MS, ठोको ताली. MS do MS का मतलब क्या है? In MS you do MS मतलब के sir in Morrissey smelly we do malar flexion and shoulder traction. MS, malar flexion, shoulder traction. Okay, it is understood to all of you. बेटा क्या हो गया? Why are you sad? ये कौन है जो sad smiley दिया है? Okay, yes. And similarly, there is a Wigard-Martin maneuver. So again, how? Okay, so MS do MS. Okay. Morrissey smiley wheat, do malar flexion, shoulder traction. And lastly, last question, Piper's forceps. 2027 NEET PG Virgin MCQ 3 साल के बाद आएगा, वो भी NEET में, और FMG में और 1 साल के बाद 2028. Piper's forceps is considered the best method for after coming head of the breech. Okay, why is Piper's forceps considered the best? Okay, yes, Piper's forceps can be used. Okay, so please is this clear to all of you? ये आपको याद नहीं रखना है कि Pinard's maneuver for lower limb, Prague is dorsal and Losset's I come to know from the scapula position. ये याद रखना है. What are the maneuvers for after coming head? Morrissey smelly wheat. Name you have to remember: Burns-Marshall maneuver and Wigard-Martin maneuver. And lastly, Piper's forceps. Now, why is Piper's forceps considered the best? Okay, why is Piper's forceps considered the best? Because it's a controlled delivery, sudden decompression is avoided. Okay, and basically fetal safety. Okay, in all the other In all the other, we are pulling the baby neck. So there could be neck injury, brachial plexus. Forceps blade go right inside the vagina. We catch hold of the baby and get the baby out. So neck traction is avoided. Okay, so now again clap if you feel happy for the first time ever. Picture अभी बाकी है मेरे दोस्त. The toughest version. ये समझ में आ गया. Burns Marshall maneuver. Rotate the baby towards the maternal abdomen. And all of you clap if you feel happy. This is the Piper's forceps to deliver the after coming head of the breech. Okay, now again, first imagine, all of you, I'll show you the picture again, first imagine the baby to be hanging down only. Okay, first imagine the baby to be hanging down. Okay, all of you pay attention. First khali head andar hai, imagine the baby to be hanging down. Okay, head is inside. अभी आप लोगों को इतना ही याद रखना है कि एक नाम याद रखना है, पाइपर्स फोर्सेप्स. पाइपर्स फोर्सेप्स इज फॉर आफ्टर कमिंग हेड ऑफ ब्रीच. ओके, नाउ सी द फन. ओके, अगर आपको एग्जाम में ये पिक्चर फर्स्ट टाइम भी आ गया, ओके, नाउ इट इज हाफ वे लाइक बर्न्स मार्शल. कि सपोज ये हेड है और ये बेबी का लोअर लिम है. So if I keep on rotating the baby up, and full head will come out, what is the maneuver? Anybody? If I only rotate catch the lower limb and rotate it up, and let the head come out, what maneuver it is? Burns Marshall. Correct? But instead of that, very good, all of you. Okay? Instead of that, if I catch hold of the lower limb, and I rotate it up only till here. मतलब बेबी को पूरा नहीं घुमाने का, बेबी को ऐसे बना दिया, parallel to the ground. Now let the assistant hold the baby, and then from the baby's anterior aspect, if I apply the forceps blades and get the baby out, that is the Piper's forceps. That means all of you please pay attention. Last 3 minutes. Okay, here sir, first again imagine the baby to be hanging down. Imagine the baby to be hanging down. So back, doctor is standing over here. Okay, so the back is facing the doctor. Yes. Okay, back is facing the doctor, and the assistant will bring the baby up till the baby is parallel to the ground. And from the anterior, can you see the forceps blades being applied? That is the Piper's forceps. So please understand this. I have shown you the picture. ये पिक्चर आपको वर्जिन MCQ है, इमेज बेस्ड. लेकिन all of you please pay attention. Even if you don't know the just a second. Okay, even if you have never seen the picture in your whole life and you are, because Vigard Martin में कुछ नहीं करना है, you just have to remember the name, Vigard Martin maneuver. I'll tell you what it is. More and more you don't have to learn. Okay, you have to learn only what is required. But Vigard Martin में it is a combination of you give malar flexion and then you give suprapubic pressure. Okay, so Burns Marshall you hold it up. Maurice's Melly में malar flexion and shoulder traction. And Vigard Martin में थोड़ा सा malar flexion and then suprapubic pressure. So just remember the name. How the maneuver is to be done, they will not ask you only ever. That is when you become a gynac. Okay. So अगर आपको exam में सबसे पहले ever in your life if you get this picture, okay, then also by looking at the picture, all of you look on the board and tell me yes or no. Is the foot delivered? Yes sir. Is the buttocks delivered? Yes sir. समझ में आ रहा है ना, ये deliver. And is the head inside? Head is still inside? Yes sir. Yes or no? By looking at the picture. Yes. Can you see the uterus? Can you see the pregnant lady? Yes. So head is inside. तो ये after coming head का बात हो रहा है. Something to do with after coming head. पिक्चर देख के इतना समझ में आया, पिक्चर देख के समझ में आया कि सर आफ्टर कमिंग हेड का कुछ तो डिलीवरी हो रहा है. एंड एनीबडी एंड एवरीबडी, कैन यू सी दिस फोर्सेप ब्लेड्स? ऑफ कोर्स सर, ये फोर्सेप का ब्लेड समझ में आ रहा है. तो इट हैज टू बी पाइपर्स फोर्सेप्स. ठोको ताली. सो दिस इज हाउ, प्लीज अंडरस्टैंड दिस. आई एम रिमूविंग योर फियर ऑफ इमेज बेस्ड एमसीक्यू, क्योंकि स्टूडेंट को इतना फियर सर, इमेज टेंशन 10 days classes are conducted only on image. Stupidity. Please understand that image is always, if you just know the theory and if you look at the picture, 100% at least in OBGY, all image you will be able to answer. कि clearly sir, ये देख के समझ में आ रहा है कि ब्रीच बाहर डिलीवर हो गया है, हेड अभी भी अंदर है. तो ये ब्रीच डिलीवरी का कुछ तो खेल चल रहा है. एंड ये फोर्सेप ब्लेड दिख रहा है, हेड अभी भी अंदर है. तो हेड डिलीवरी के लिए कौन सा फोर्सेप्स है? Piper. That's why theory should be very strong. Any MCQ, directly you solve MCQ, waste of time. First listen to theory, then go to MCQ. That is how you will master the topic. Directly, if I solving MCQ, for the delivery, all this, no problem. That's why always theory and then MCQ discussion is what is the best way to clear the exam. Yes, for exam you just say shortcut, and towards the end you only solve MCQ, very good. But first you have to listen to this theory class. Is this clear to all of you? So nobody is going to ask you all this. Just remember, Burns-Marshall maneuver is for after coming head. This image we need to keep in mind. And this is of course a virgin MCQ, but yes, again please keep in mind, this is the Piper's forceps. So this we will wind up our session today. This is only part of it. Don't worry, tomorrow when I meet, I will discuss when to do cesarean section for breech, what is ECV, all that we will discuss, and then we will go on to discuss about the transverse lie, oblique lie breech, and superb class about mal position. Do not miss out. And very, very important topic of postpartum hemorrhage and also instrumental delivery forceps vacuum, and time permitting also VBAC and trial of scar. So today we did physiological changes in pregnancy, placenta, normal labor, active management third stage of labor, and mal presentation 50% is over. Face and breech is almost over, but breech ka baki ka part baki hai. And tomorrow we will discuss the breech, then transverse oblique brow in the first 1 hour, and then second hour this, and third and the fourth hour this. Okay, so all this will be done tomorrow, Tuesday. Then Wednesday, the preeclampsia and the heart disease, and Thursday will be the APH and the remaining topics. Yes, okay. So all this we are absolutely on target and time. Okay, and then last turn which will remain will only be like images. We'll show you all the images again together. Okay, is this clear to all of you? So thank you very much for coming in today. And as usual, please, all those who haven't yet subscribed to the Telegram channel, also please, I'll post it today also. And also those who haven't subscribed to the YouTube, because we have 150 students. Okay, so all this, and as a last thing, please tell, superb, everybody is really happy. Please tell all your friends and colleagues about this app, those who only want to study OBGY, because there are many students who may want only OBGY lectures. Okay, so please tell your colleagues and friends about this OBGY app, and all of you also definitely do subscribe to the YouTube channel. And also, so there are theory lectures, MCQ discussion you get, and you get all the other features like my timetable guidance also, and of course the phone numbers are there, 100% strike rate.